and, you know, the athletics you take care of. And I would say, you know, when I can get you the guidelines of the protocol, it'd be important to go through those things, make sure you have a plan, make sure you practice it with the individuals that are going to be there. You want to be smooth if you have to take care of one of these patients. And, you know, one other thing I would recommend to you all is, you know, a lot of times these patients initially get taken to another hospital, another facility that can't care for these patients. And I think that's an important point here. The last point is make sure you take to a hospital can provide immediate, definitive, and I think the key word there is definitive care for these patients. I get a lot of patients with incomplete spinal cord injuries that initially go to a smaller hospital and then end up at the medical center. You know, if you think somebody has an unstable cervical or any spinal injury at all, please just bring them down to us because they're going to end up with me anyway. And it just delays their care going to an outside hospital and then somebody having, you know, getting a scan there and the ER doc calling the spine surgeon because they're not going to take care of it. And they're going to say, send it to the med center. And, you know, time is critical with these patients and they could get worse. So, you know, I would encourage you all to, you know, I'm not trying to our bargain for business here, but that's what happens in our city of Houston here. So, you know, it's fine if those outside hospitals, you know, come to you and say, you know, we want to take care of spinal injuries, but the current system is that they all end up at the med center. So it would be better just they come straight to us. And I'd like to thank you all for inviting me to talk today. Anybody have any questions? Time for questions. Okay.
Morning. My name is Mark Phillips. I'm with Memorial Hermann. It's my pleasure to introduce the next speaker. On page 4, you'll see Dr. Shani's bio, and that's very similar to what I'd written down to introduce him, which is all the gobbledygook of everything. So what we need to do is introduce Dr. Shani to you in what is not written down. He's a graduate of Memorial High School here in Houston. His undergraduate is in biomedical engineering. Worked with Georgia Tech and the Falcons when he was doing his fellowship. He's the team physician for Lutheran High North, St. Pius, and works with Waltrip High School out of the Memorial Hermann Northwest campus. And in some of our conversations, we're discussing what really interests him as a doctor. He has the list of operating on knees and shoulders and all those things like everybody else does. But he told me what really interested him is the tissue in the body that doesn't heal. So let's find a tissue in the body that doesn't have a vascular supply, gets its nutrients from the surrounding fluid, and loses its ability to heal right about the second decade. So that would be the meniscus. And so his challenge to himself is to find a way to improve the techniques that are used in dealing with that structure. So please welcome Dr. Shani. He's going to talk to us about meniscus updates.
Thank you, Mark. I chose this topic, this is actually in contradistinction to what Mark Bashan was talking to you about, the spine injuries, which is a very devastating injury, but you won't see it that often. This you will see, while not as devastating, but you will see, and it can affect your athlete's ability to return to play. So I wanted to go over what the literature says, what's some of the background, and where are some of the features that's going to take care of the meniscus. So what is the most common orthopedic procedure that we do? The most common one we actually do is the knee arthroscopy with partial median meniscectomy. Its incidence is about 60 to 70 in about 100,000. It's more common in males. It happens in about 1/3 of ACL tears, and it actually is more common the lateral meniscus is involved rather than the medial meniscus. Men, it actually happens from 20 to 30, whereas women, it actually happens a little bit earlier, and I think that has to do with the collagen as they're growing and maturing. And it is associated with the tibial plateau fracture. So what are the historical perspectives? And I think it's important to understand that, again, this is not a new diagnosis. Something that was actually described well before we had advanced imaging. It was described in the late 1800s by Dr. Hay, and he decided it's an internal derangement. And he actually proposed the idea of actually repairing these meniscuses and doing treatment on these meniscuses back in the late 1800s. Why is this important? What's the end game if we don't take care of the meniscus? Well, it eventually leads to degenerative arthritis in the knee because you lose the contact forces in the knee. And you can see here that over time, that what happens is that if you don't take care of the meniscus, it can lead to arthritis, squaring off the cartilage, and loss of motion and loss of activity. So it has to do with the function of the meniscus. The function of the meniscus is that it involves load-bearing activities, and it involved in not only a secondary stabilization, but it's also a shock absorber of the knee. So this small little tissue provides an extremely important biomechanical function to a very important structure of the knee. So when we look at how much load is involved in the meniscus, this goes back to my biomedical engineering background. We actually want to look at what's the load transmission. This study said that actually in the lateral meniscus, about 70% of the load actually goes through that meniscus in the lateral compartment, whereas the medial meniscus only takes care of 50%. This is very important to remember when we look at treating lateral meniscus tears versus treating medial meniscus tears. The lateral meniscus tear actually takes a longer time to recover because it contributes more so to the load than the medial meniscus tear does. And that's why there's more chance of developing lateral compartment osteoarthritis in the knee if you do have lateral meniscus tear. Partial meniscectomies actually decrease the contact area by 10%, which actually can lead to about 65% increase in peak loads. What we used to do back 20, 30 years ago is we used to remove the entire meniscus, and that used to have substantial increase in the load that the knee felt, and actually up to 235% of increase. So the meniscus, while being a small structure, decreases the effective contact surface of the knee, which decreases the effective pressure that the knee is feeling. So how do these tears occur? This was a study that looked at NBA players, looked at all comers of NBA players who've had a meniscus tear. And the actual most common way was insidious. When the player just came to you a couple days later saying, I have pain in my knee, I don't know what happened, I just have pain and swelling in my knee. And that's actually the most common way people tear the meniscus or present to you with meniscal type pain. The second one is an acute non-contact, and the final one is a contact with the player. But I just wanted to reiterate that the most common way was just a patient or an athlete that comes to you saying, I don't know why I have pain in my knee. So the diagnosis is pretty clear. I'm sure you guys all very familiar with that. It's a twisting injury causes clicking, catching, loss of range of motion, and a fusion. Go into some of the special tests that you look at, the joint line tenderness, which is the most common and most easily way to diagnose a meniscus tear. There are some more advanced testing, the Thessaly test, McMurray's test, and the Apley's test, which I'm sure you're all familiar with. But I just wanted to go over what the sensitivity of those are. They're all pretty high. So if you have a patient that has one or two or more of these signs, you can reliably say that they most likely have a meniscus tear without having to necessarily get further imaging. When we do get further imaging, we typically get an MRI. An MRI typically will show a signal from, we're looking at a sagittal view here, looking at a signal here, increased signal in the meniscus right over here. The best ones are usually the bucket handle to tell on MRIs. So we classify these on grade 1 to 3 when we look at MRIs. Usually the MRI is showing a small blush, or the worst type where it extends a tear from the superior aspect all the way down to the articular surface. The types of tears are important to know because we describe these type of tears so that much more than we know the outcomes of these tears and how they do and how we can treat them. They range from a longitudinal, oblique, more degenerative type tear, and radial and horizontal. You know, these radial tears are important to understand because sometimes they can extend backwards and they may or may not be able to be repaired or not. Whereas these longitudinal tears, we try to repair if they're long enough to repair. And we'll get into that a little bit later, but in describing these tears and how you communicate these tears, this gives you a little bit of background on how we describe and how we classify these tears. So what are the treatment options? Well, they range from non-operative to operative, and it has to be stratified on the athlete and their clinical symptoms. But these range from physical therapy, bracing, injection therapy, operative to meniscectomy, meniscal repair. We'll go into a little depth about that, as well as meniscal transplants in the patients that have failed other meniscal treatments. So what about therapy versus surgery? In which patients should we say, you know, you need to go for an arthroscopic debridement, or you can try therapy? Well, this was a study that looked at all comers in symptomatic unstable tears. What was defined as symptomatic unstable tears? Tears that have mechanical symptoms, catching, locking. And what was the data that they found when they randomized these data to physical therapy alone or treatment with physical therapy? And the outcomes actually showed that the pain and swelling decreased with therapy alone, but what they didn't get back was that range of motion and that ability to return to play. So in this study, they actually recommended that arthroscopic partial meniscectomy was the preferred treatment of choice for someone who had a symptomatic unstable tear. What do we do in meniscectomy? Well, it's an arthroscopic procedure. I'm sure some of you have seen these. If not, more than happy to come watch me do a few of these cases, where we go and just debride the meniscus back to a stable rim. So you have a flap tear or a tear that's flapping in and outside the joint. We go and we partially smooth out the tears to remove any of the mechanical inciting factors. So what's the data between partial and total meniscectomy? Well, obviously, as we know, take more out, you're going to increase the contact areas, you're going to have more long-term effects, but short-term, actually, you don't see these effects. So back in 20, 30 years ago, when they were removing all these meniscus, patients were actually getting back to play, but only later on in life did they realize, oh, they're developing arthritis. And that's why we try to preserve as much meniscus as possible. Again, what about the medial versus lateral meniscus? Because of the higher contact forces that the lateral meniscus takes care of, it has a higher rate of osteoarthritis that it develops. What about the predictors of recovery? When do they recover? Well, the only thing that in the short term that says recovery-wise is more important is their previous extensive level of arthritis. But long term, you can see that their level of weight, how much meniscus we do take out. If we involve both meniscus, they can have a certain impact on how they recover. Again, this kind of tells you guys a little more about what's the more clinical impact on how they're going to do. And it's really depending on not necessarily the acute setting, it's depending on how much cartilage damage they had with the initial injury. So if it's just an isolated meniscus tear, they can have substantial good recoveries, especially in the short term. But in the short term, if they have a cartilage injury that goes with it, then they're going to have a less chance of having as good as recovery. What about return to play? When we look at return to play is very difficult to understand as opposed to return to performance. We try to distinguish these things. This was a study that looked at return to play as opposed to medial and lateral meniscus tear in high-level athletes, and they had on an average about 45 days for the medial meniscus, and in contradistinction to the next study I'm going to show you, they had about 46 days. So similar in this study as far as return to play. But this actually study was a little more well-designed studies that looked at more of a long-term and return to performance category in 90 arthroscopic partial meniscectomies, and this was looking at in elite professional soccer players. They compared medial and lateral meniscus here, and on average they had about a 7-week return from a lateral meniscus tear as opposed to a 5-week return from a medial meniscus tear, and this was statistically significant. I think this goes back again to the biomechanics of what's going on in the knee and the increased load and the increased importance of the lateral meniscus as opposed to the medial meniscus. What about in NFL players and getting back to play? Does it have an impact on when they were drafted? This was an interesting study done out of ASMI by Dr. Andrews that looked at when players are drafted earlier as opposed to later. How quickly are they able to get back, and are they able to get back to the level of performance, the previous level of play, based on what their draft status was? And what we found is that in the first 4 rounds, they were 3.7 times more likely to return to play as opposed to the players that were drafted afterwards. Speed positions were less likely to return to the level of play as opposed to non-speedy positions. And the mean time to actually return to performance, which I think is very important to look at as opposed to just return to play, was actually much higher. It was actually up to 8 months before they actually were able to meet some of their criteria and the guidelines that they were prior to the injury. Now, what about repair? Mark kind of touched on this, and something that we want to do because of these meniscus can have such a great impact on their long-term player is we are trying more and more to repair these tears if they fit the criteria that they can be repaired. And it has to go some of the basic science of the meniscus and understanding the blood supply of the meniscus. The blood supply of the meniscus primarily gets its meniscus from peripheral outer 1/3. This is the inner part of the meniscus we see in the joint. You can see here that the blood supply in this cross section is only on the outer 1/3. And we classify this as kind of the red zone because this is where most of my bleeding is, as opposed to the red-white zone and the white zone here where there is no healing. It's very difficult for the meniscus to actually get healing regardless of what we do. Some of the indications or main things is that it's in that peripheral 1/3 tear and they don't have extending level of arthritis in the knee, and they fit the other criteria that are having ligamentous damage as well. That makes it an unstable knee joint. So what are the techniques that we are using now to repair meniscus? Well, they range from the arthroscopic inside out, outside in, and all inside. What we mean by this inside out is that we start the repair from the inside of the joint and then we tie the sutures on outside through a separate incision. I'm going to go through that right now. So what we do is we take the meniscus here, we're looking inside the joint, and then we have these arthroscopic needles that have sutures on them, and then we take them outside the joint, we make a separate incision, and we tie these on a separate incision. This is classically known as the gold standard of how we used to repair meniscus tears, and I'm sure you'll see a lot of this done in the community of bigger meniscal tears, and this is how they were repaired. The main structures at risk are the saphenous nerve, and laterally we do is the peroneal artery and the popliteal artery. As opposed to an outside in, where we actually start the repair from outside the joint and work our way in and tie it over a bony bridge. So we're starting here on the outside of the knee, sticking a needle through the knee, through the meniscus, and then tying it over a bridge on the outside. What we're doing more and more now recently is an all-inside technique, and what these involves is commercially available devices where they have the suture button on the end, and you poke the suture button through the meniscus and then tie it over a knot to get it to heal. The complications are small, usually about 2 to 3%, and usually do heal quite well and resolve pretty quickly. So what are the results? Do these meniscus tears actually heal? This is the most important thing that we're looking at, as Mark was describing earlier, because the blood supply is so difficult and so tough to stimulate in certain patients. We have to understand, are we actually getting these meniscus to heal? There are anatomic and clinical criteria. Main way we can look at it, we can get an MRI. An MRI, actually, repeat MRI has shown that it has a good success rate, about 75% way of actually understanding if the meniscus is tear, and that's correlated with clinical symptoms. But the interesting thing we found is that actually 2/3 of patients who have a re-tear actually are asymptomatic. And the reason why we think this is that actually incomplete healing is actually enough to allow these patients to be asymptomatic and return to activity. So as long as we can get some healing across the meniscus, that's better than having to take the whole thing out and going back to the process of then developing late-stage arthritis in the knee. So this is why we try to repair. This is why we try to use other techniques. A lot of other techniques are coming along the way, augmenting with PRP, bone marrow aspirations, to try whatever we can do to get this tissue to heal. And the studies have shown that these we've gotten to increasing the rates of healing in these tears that have met the clinical criteria all the way up to 60 or 91%. But the main thing is that if we can get past that first year tear rate, which goes all the way up to 20%, that's a really good sign in these young athletes. This was a couple studies that actually looked at the meniscus and looking at the tearing of the meniscus and what are the outcomes. This was an 18-month study and looking at 312 patients. They found that that when we have a failure rate without an ACL tear, it's actually about 14%. But when we do an ACL with it, it actually decreases the rate of healing to about 6%, which is a substantial improvement. They found in this study what was the most important factor was that rim width. That rim width was 3 millimeters or less off the peripheral meniscus, then it had a very good chance of healing. And age, when we look at age, in our patients, again, the most important thing was actually the location, that they've had good success rates in patients that are above 40 with this, if we can get appropriate healing, get appropriate blood supply into that knee. What about the tear length? We talked about it. If the bigger tears, if they get up to 4 or 5 centimeters, they become a lot more difficult to repair. But these in-between tears are from 2 to 3 centimeters, we can repair, and we have good success rate with those. What about, again, looking at all inside, the data between all inside and all arthroscopic versus inside out? The data actually shows that we're becoming more and more efficient in having less morbidity, less complications, and quicker surgery with doing the all inside technique, especially with some of these augmentation factors, PRP, bone marrow simulation, fibrin clot. These are things that we can add to get the meniscus to heal. Finally, there was no difference found in any of the range of motion or outcome scores. This was another study that looked at the meniscus tears and also had similar clinical failure rate, and the overall outcomes were about the same. What about when we do meniscus tears and ACLs, as I alluded to earlier? That actually, when you do an ACL reconstruction, the outcomes of the meniscus is actually better. And why is that? Well, because you're inciting all this hemarthrosis in the knee, and those hemarthrosis, when you drill the tunnels for the ACL, actually do help the meniscus heal better and have a better outcome than doing the meniscus alone. So that actually is another reason. So if you have a tear with an ACL tear, they actually have a better outcome of repairing the meniscus as opposed to if you just had a meniscal tear alone, which is contrary to what most people would think. So what about rehabilitation? How do we rehabilitate these as opposed to our normal when we do just a meniscal debridement, which could get the patient back to play quicker? We have to go a lot slower with our return to play. And how do we immobilize them? How do we get them stronger? When do we start weight bearing? These are all controversial topics that have to go with understanding the biomechanics of the repair and how patients are healing. Initially, what we used to do is we used to mobilize them, keep them in a brace, tell them not to walk on it, and allow the meniscus to heal as we were protecting. But as we've evolved in this, we've actually started patients to weight bear, more accelerated rehab, and we've not changed any of the rehab as opposed to when it's just having their ACL done. So this was a study looking at an all-inside repair, looking at weight-bearing and accelerated group as opposed to non-weight bearing, and looking at the outcomes. And the actual outcomes with actually getting them up, getting them walking, and even with a brace or without a brace, showed that they had similar outcomes. So we're learning here that we can actually get the knee to move quicker, get the range of motion back quicker, and move the knee further along than we've been able to do in the past. And I think this has to do with better fixation techniques and better understanding of the biology that's going on in the knee. So when do we return to sport? This is a very complicated answer because we're trying to move away from time guidelines and saying, okay, you're at 5 months, now your time to return is now, you can go back and return. We want to look at more of a functional guidelines. This is one study that proposed functional guidelines of when we can return a knee, looking at subjective knee evaluations, no effusion, full range of motions, looking at also strength parameters that they at least get to 70% of normal before you initiate return to play activities, not necessarily that they're returning to play, that they can start getting into a practice level, they can start getting into more aggressive activities that simulate play, but not necessarily getting back to full play. And that's a decision that has to be made with the trainer, the doctor, rather than just any time or specific objective guidelines. So what is the future of meniscus? what are we going to do if we can't repair the meniscus? Are we going to just leave it alone and let the athlete develop arthritis later in life or not return to sport? Well, there's been a lot of new exciting research on what we can do to try to replace the meniscus. One of the things that's come recently along is, especially in Europe, and they're doing is synthetic replacements of the meniscus, where we actually have a synthetic device that we actually were able to implant in the knee and repair it with sutures as we would do with the meniscal repair. And there have been some good early studies out of this. What about transplant? This is important for the patient that's had a previous meniscectomy and they're developing pain due to the meniscus. What can we do to try to get this meniscus to heal, or try to to preserve the meniscal function, preserve the shock absorbing effect of the meniscus? And there's been a lot of research done on meniscal transplants. It was first described in 1984. And it has to do, first we have to talk about graft processing. You can get a cryoprocessed, fresh, frozen, and fresh lipophilize. And it has to do with is what the donor time is and some of the viable donor cells that are involved with that. But typically I wanted to show you what are the types that are involved. It's usually best done when it's fixed to bone. There's two types. You can do a soft tissue type, or you can do a bone bridge or a bone plug. I'm going to show you some pictures of what that is. You repair, you take the transplanted allograft that you get that's donored, that's cross-matched, and you repair it, and you tie it over a bone bridge or a bone plug, as opposed to using a bone bridge on a lateral meniscus. You can also do direct soft tissue repairing as well. But the idea is that you're replacing the biomechanical function of the knee, and that then the meniscus is immunoprotected because it's in the knee joint. It's not necessarily seeing the rejection factors that you would see in other transplanted organs. Another picture of the bone plug that's involved, and a keyhole device where actually we take a bone keyhole and make a keyhole and replace the meniscus to where it used to be. So what are the indications? This is obviously more advanced treatment for the athletes that have failed the other two treatments, meniscectomy and possible repair. You want to have a stable joint that's particularly involved. You want to minimize the cartilage deficits, because at the point where there's cartilage injury, this procedure does not become as effective. It's also indicated in patients that don't have an ACL, because we got to remember that the medial meniscus is also a secondary stabilizer to anterior translation. So if you don't have an ACL, this meniscus can provide that secondary stabilization. The contraindications are basically if they have any malalignment, or if they've developed arthritis to the point where that you can't do this procedure. The rehab is tough because, we're still trying to do a lot of these, and how do we rehab this? But I think the main goal is to kind of rehab them as you would rehab a meniscal repair, because you're trying to get that same type of healing response. You would go a little slower than you would with the meniscal repair, but the typical protection and the same biomechanical thought processes are there. So failure, how do these fail? Well, these are usually a biologic failure rather than a mechanical failure. Again, you're inciting allograft or donor tissue into the knee. So you want to have as much healing factors, as much of the more biological factors. And I think that's what's going to help meniscal transplants have better outcomes in the future as we understand more of the biologic factors, whether it be own blood cells, stem cells, or in addition to the transplanted meniscus. What are the results? This is results out of a doctor I trained with in Belgium that looked at all comers of meniscal allografts, and the results are pretty good. They had significant pain relief. Overall, they had about a 75% satisfaction rate in meniscus in meniscal transplants. So this is something that's more evolving and getting better. Ideally, we would like this to get up to more than 90-95% range. Overall, again, this is another study that showed a good success rates, and when they did fail, the failure was more in the lateral meniscus, and now we understand that why, because more of the biomechanical forces are placed on that lateral meniscus. So in conclusion, meniscus tears are very common, and you have to be able to recognize it, and you have to be able to know the appropriate diagnosis. And then once you know the appropriate diagnosis, the treatment is based on how the patient is presenting, and the treatment ranges from physical therapy, non-operative management for more of those stable meniscus tears that are improving with time and treatment, or proceeding with a procedure on those unstable meniscus tears that are having mechanical symptoms. The treatments can range from meniscectomy to meniscal repair, depending on the tear of the meniscus. And eventually, if they do fail those two previous treatments, then meniscal transplant or meniscal allograft are options that can be available to the patient. Thank you.
Is this, now that's on. All right, we're going to go ahead and get started with our next presenter, talking on alternative tools for Olympic weightlifting. His name is Rashad Ford. He is a certified strength and conditioning coach with the Ironman Sports Medicine Institute, based at the Memorial City location, as well as our Shepherd Square. In his spare time, Rashad enjoys playing slow pitch softball. He's a very good pitcher. So, I mean, he looks the part. He looks like he could probably run a 4.2 40 still. So, hopefully you guys get a lot of good information out of this, and it's really fun and kind of demonstrative for everybody. So I'll turn it over to Rashad, and he's got it for the next half hour or so.
Thanks, Stephen. Can you guys hear me? All right, sweet, good, we're on. All right, let's sit here. Okay, cool. All righty. So how's everyone doing this morning? Good, good, good. Hopefully, you guys will get something out of this. Hopefully it's entertaining and some good take home. But before we get into the actual presentation, I want to give a little story. Where do we point this thing at? Okay, here we go. My first encounter with Bob Marley. So, of course, we know Bob is an athletic trainer. Covers mainly your smaller towns, which I'm from. So anybody know about Bowling, Texas? We got a few. All right, go Bulldogs, yeah. So Bowling, very small town, population, which I just looked up, is around 1,432 people, but they're probably rounding in Iago, New Gulf, those smaller towns around there. But also Bowling is known for Mock's Restaurant, if you guys know where Mock's is, and also their one and only stoplight in the whole town. So very small town, but my encounter with Bob was back in 2003. I was a senior on the football team, and small 2A school, of course, you have to play both ways. So offense, defense, also special teams. Some of you guys may know about that. But I remember cramping around the third or fourth quarter, and I remember Bob giving me a drink. It was orange. I remember him shaking it up. I'm not exactly what was in it, but I just really remember that it was very bitter. And very salty, of course. So I don't know if it was just pickle juice mixed with tang. Who knows what Bob gave me? But anyway, it worked. But I want to thank Bob, though. He had a huge influence on my career path as far as where I'm at today. He may not be in the room right now, but I do want to thank him for that and also thank him for this opportunity. But let's go ahead and get into it. So topics to discuss: benefits of Olympic weightlifting. To Olympic weightlifting or not, when to implement Olympic weightlifting. We're going to talk about the pull, also ditching the bar, maybe some alternative exercises for Olympic weightlifting if your athletes are not ready for it. But Olympic weightlifting has been around for many centuries. I'm not too sure exactly where it started. I mean, different countries are going to go back and forth to where the originators of it, but it is a very popular form of exercise here in the US now, thanks to CrossFit, but which is a good thing. Lots of pros and cons to Olympic weightlifting, but some of your primary exercises when you think about Olympic weightlifting, we got your power clean, your hang clean, power snatches. We're doing push presses, high pulls. Also, some athletes are starting it from the box depending on the skill level and also the height of the athlete, and I'll get into that a little bit also. But some of the supporting exercises, which I really should have put prerequisite exercises, because if these athletes don't have a good foundation of strength, if they're not able to do the supporting exercises, surely they're not going to be able to do, well, not going to be able to perform the Olympic style exercises with the barbell. So the athlete first needs to know how to front squat, know how to overhead squat. I'm sorry, not overhead squat. Overhead squat is another one, but also RDL and also military press. But benefits of Olympic weightlifting. I mean, Olympic weightlifting is basically from toe to head. So a lot of muscles involved, just about every muscle is involved. So with that, I mean, of course, it's a great metabolic training. You're expending more energy, you're going to burn more calories. Also, it's good for increasing power production, and a huge plus because we have so many things going on today. It also doesn't require much time. I know for a lot, maybe in a high school situation where I think most of you guys may be right now, Of course, you guys have a certain amount of time allowed it as far as weight training or with the students, period. So that gives you an opportunity, if those athletes are there at that level, to maybe get in maybe 30, 40 minutes and spend a little bit more time on the field, on the court, wherever they may be at. All right. So Olympic weightlifting versus plyometrics to powerlifting. There are many different ways to get your athletes better these days as far as athletic ability. But research has shown out of these three, Olympic weightlifting has shown the best as far as power production. I think, there we go. Not only power production, this is looking at counter movement here, but also in your 5 meters, 20 meters sprint ability, and then also your horizontal jump, which is going to be more likely your broad jump. So looking at those three, I mean, they're all good, but when the options of which one's going to give you your biggest bang for your buck is going to be Olympic weightlifting. So to Olympic weightlift or not, like I said earlier, a lot of the pros and cons when it comes to Olympic weightlifting, and not only Olympic weightlifting, we're talking about resistance training also. Nonetheless, if you're active, I know previous speakers, they spoke a lot on injuries, whether it be spine, whether it be knee. There is always a chance of an injury nonetheless. But research has shown, and it's kind of back and forth, but Olympic weightlifting actually being one of the safest forms of resistance training. So a couple of reasons, well, a few reasons to Olympic weightlift or not. Like I said earlier, full body exercise, great way to increase power output, improves functional skills like I spoke on earlier as far as counter movement jump, 5 to 20 meter sprint ability, also your broad jump. I mean, it's going to have a greater translation to the actual sport opposed to just your basic resistance training and plyometrics. Also, cardiovascular improvements. Research out by Sloan showed a 12-week base test as far as comparing Olympic weightlifting resistance training actually showed an improvement as far as decreasing resting heart rate, also resting blood pressure. So a lot of improvements as far as with Olympic weightlifting. Also improved body composition. Very similar research showed that there was also an increase, 6% increase in lean muscle mass also compared to regular resistance training. And like I said earlier, big workouts in a short amount of time. So you can spend 30, 45 minutes and basically you got a full body workout. A couple of bad reasons, which we see often, possibly in gyms, possibly in a high school setting, wherever you may be. But everyone wants to stand out. So some may perform some form of Olympic weightlifting just to be cool. Or maybe they want to get into the group and maybe socialize with their friends a little bit more. Or maybe in another sector where Olympic weightlifting is kind of known to be of a cult. If you guys kind of get where I'm going, I'm not going to call their name out there. But it's one way. And then also you want to be that guy at the gym also that's known for performing those cool lifts. So a checklist that I typically go through before I even prescribe an exercise for the athlete, as far as I have to do evaluation of myself. So first of all, am I even knowledgeable about the lifts? I mean, if I can't explain to the athlete why we're doing this or even how to do this, there's no reason for me to even prescribe it to the athlete. Also, can I demonstrate good form and technique? Can I recognize technical flaws, which is very huge. I mean, typically when you're first giving exercise to an athlete, whether it be jumping, whether it be a bench press, a push-up, things of that sort, very simple things that we may think about, but yet they may actually be lacking the actual neuromuscular ability, also maybe the foundation of strength to actually perform the exercise. So there needs to be some form of possibly a regression. That way we can get the athlete to the next step or get them to where we want them to be, which I touched on also. Sweet. All right, so who are you training? What are the needs of the athlete? So let's say I'm training a marathon or a triathlete. Typically, I wouldn't prescribe Olympic weightlifting, typically because, I mean, their sport's endurance. Now, they do need some form of power, of course, but there are many different ways in which I can get them there. Also, are they injury-free, which is very important? Do they have good functional movement? Are they able to get down into a 90-degree squat? I'm not looking to get below. If they can't, hey, great. And also be able to maintain good form. Do they have time to learn, which is another big thing. Like I spoke on earlier, you guys may have a short amount of time or a certain amount, a lot of time in which, hey, you know what, for some strange reason, this athlete is just not picking up the exercise right now. And instead of spending 3 to 4 weeks, which you may only have a total of 6 weeks with that athlete at that time, let's go on and do something else to get this athlete better. Is there proper equipment available? Which in most situations, there is going to be equipment available to use as far as a barbell and some plates. Are they coachable, which is very huge. Olympic weightlifting, I've seen it taught from kids down to 8 years old to also adults, maybe in their 50s or 60s, possibly older. So with that being said, it's just all about the mindset of the individual or the athlete. And finally, will it meet their needs? So the pull. So typically at the pull, that's where a lot of power is generated. So what we're looking for there is a triple extension. What I mean by that is the extension at the ankles, the knees, and at the hips. So recruiting the posterior chain, which are going to be your hamstring, your glutes, some of your larger, stronger muscles, but highly overlooked muscles also when it comes to training. And kind of getting to know your athlete also. So the individual to your left, he is actually pulling from box and starting there. The reason being because he's 6'8". So for me, I wouldn't put him on the ground or start the barbell from the ground because he's going to be at a disadvantage. So typically you want the barbell to start about maybe mid-shin height. Athlete to your right, of course, he's much shorter. So it all goes about knowing your athlete and putting them to their best. I mean, setting them up for the best success as far as the exercise. So few basic exercises to start off when we talk about Olympic weightlifting is a high pull. High pull is a great way of following up exercises as far as possibly your hang clean, your power clean, things of that sort. It's just getting the individual used to actually pushing it into the ground, recruiting those muscles. So like I said, your hamstring, your glutes, that posterior chain, and just teaching them the basic movements in which is going to follow up. So to start off, have the individual go from left to right, just starting off regular position. From there, lowering down to that centric. So what I kind of like to use is somewhat the rubber band method. So if you were to pull back a rubber band, would you get more potential if you let it go as far as power, if you let it go right away, or if you were to hold it maybe for 20, 30 seconds? Now, of course, you're going to get more power. It's going to fly further if it's held for a short amount of time, if you pull it back to its full resistance, of course. But over time, if we sit down there, which he is right now, of course, still, but the hamstrings aren't stretched. So you're actually losing potential for power the longer you stay down there. So that's kind of a little trick I like to use as far as explaining to the athlete as far as a rubber band. So the clean, as we see the individual, I mean, somewhat in the middle picture, getting that triple extension, like I said, looking at the ankles, the knees, and also the hips. And then finally, last picture in that catch position, forming that rack, which they're going to be at if they're performing a front squat. So going back to basically having those prerequisites checked off before they get to something like this. There's a great picture here kind of showing the different phases of a snatch. Also be the same as a power clean too. So starting off on the ground, your first pull is from knee to about mid quad. From there, transition phase in which you saw the previous picture in which he was starting at. And then going to that second pull to the turnover, which somewhat is that high pull in which he's not catching there. And then finally finishing up in the catch phase. So very complex, but yet can be very simplified. And like I said earlier, if the kid or athlete is coachable, it definitely can pick it up. So let's say for some strange reason, the athlete is not picking it up, and maybe they're not at that level in which they're strong enough to actually handle a barbell or even a training bar. Or it may be in the case where this kid, year before, he was maybe 5'10", he comes back, he's 6'8". Of course, that happens. Well, it may not be that drastic, but growth spurts do, of course, during high school. And at that time, the athlete then is trying to catch up to their body as far as neuromuscular wise, trying to get control of all that sort. So different tools that we can use are dumbbells. You got your hex bars, your kettlebells, medicine balls. Of course, we all have access to one or the other. So very easy to implement these tools. So alternative lifts, for Olympic weightlifting, you have your hex bar jump. I'm going to show you some dumbbell variations, also kettlebell variations, and also medicine ball exercises. So hex bar jump. Anybody familiar with hex bars? Use them often? Some do. Good. Great tool to have. Also teaching a kid a deadlift, or maybe that individual may have experienced lower back problems. Great thing about the hex bar, it puts the weight in the midline opposed to a barbell, which is going to put it more in the front of you and cause a little bit more flexion extension, possibly if the athlete doesn't have a good range of motion to actually get down to the barbell, but a little bit more strain on their lower back. So tool I like to use, the hex bar. Great way of recruiting power for an athlete that may not be at that point in which they're ready to perform those Olympic lifts. But you see, athlete here starting from the ground, kind of already lifting off the ground, and from there, just getting that triple extension, putting force into the ground and jumping. So very easy to coach, very easy to learn. Just about every athlete knows how to jump. We just have to teach them how to land properly. Push press, very simple exercise also. So just going down, lowering the body in that eccentric, and basically driving with that back half, hips out, pressing the dumbbells up. Most of the power, or if not all the power, is actually coming from the lower half. Basically, your arms are just basically performing the last movement in which you're doing a military press in some sense. Dumbbell snatch may be a little bit more complex, but once again, very easy to learn. And this is also good to use maybe for that athlete that may have some asymmetry, so maybe some imbalancements from left to right. Hook them up with a dumbbell or a kettlebell in which they can perform these exercises and maybe bring some balance to the athlete, opposed to constantly training them with a barbell in which you may have one side going up but the other side lagging because there's just some strength differences there. Kettlebell swing, which we've all seen before. Very easy to use. I like to use a kettlebell swing as a good foundational exercise as far as actually recruiting the posterior chain, teaching the athlete how to get into triple extension. So very easy exercise to use. All right, there we go. Kettlebell clean. Going back to that dumbbell snatch, but first movement is your kettlebell swing, in which they're coming up and actually just now catching it. So teaching them the rack position if they're unable to possibly use a barbell right now. Another tool you can easily use there. Kettlebell snatch, just showing different variations like we're going to show with the dumbbell before. Kettlebell clean and press, so taking it a little bit step further there, in which they actually get, of course, they're cleaning it, and then we're going to actually press it up. So like I said, a good full body exercise, recruiting many muscles. Should be right there. So getting to your med ball. Another very easy tool to use, also get your hands on. We may not have access to kettlebells, like I said, but most of us have access to dumbbells or some type of medicine ball, weighted ball. And of course, if you're working with, let's say, maybe children from maybe, let's say, 6 to 12, this is definitely an easy tool for them to use. I mean, they've basically been using it in some ways, possibly using the basketball or soccer ball as they were growing up. But med ball slam here, as you can see, the athlete's starting off, kind of dark there, but kind of in that lowering phase where he was earlier in the RDL, and now going up to triple extension, looking to slam the ball. So activating that posterior chain. Medicine ball, wall ball is another great exercise. So this would be a good crossover for teaching the athlete a push press, or also possibly that clean the press. So athlete typically will go down. I know for some they have medicine balls behind them. In this photo here, they want them to squat down to the ball, actually recruit. But in some sense, if you're looking to do a push press, you're going to maybe bend 20 to maybe 30-degree bend of your knees. It's not much of a flexion in which you're driving up, but definitely a great way to teach an exercise. And actually, a little story about this exercise. I actually had a NFL player going through rehab in which we were somewhat at this phase here, and he felt uncomfortable at the time performing the exercise with the barbell. So I had to pull back, and we just started him off with medicine balls. Next day, felt more comfortable. It was more of just building confidence in an athlete that can actually do it, but was able to come back the next day and perform the actual exercise with the barbell. So in some cases where it may not be that confidence factor that the athlete may have, this is a great way to not only build it, but also get them to the next level of the exercise that you want. Another one, med ball overhead toss, which you've seen in many commercials. Nike, when they do run their Spark commercials, they typically, this is one of the exercises that they use, which is a great exercise. 16-year-old tennis player, of course, tennis, a lot of power involved, but do we have the time to actually learn those Olympic lifts? Are those Olympic lifts actually going to benefit her, especially with the tennis racket? Do I want to risk her wrist as far as getting injury? So typically I would set her up with a kettlebell or medicine ball. Very easy to use. You can see she enjoyed it. She was smiling. But to leave off with, to Olympic lift, weight lift, or not. So am I able as a coach to teach the lifts properly? Is it going to fit the needs of my client? Is the risk worth the reward? And then finally, are there alternative exercises that are easier to implement at this time for the athlete? I'm all for Olympic weightlifting. Definitely, as you saw, you're going to definitely get a better workout in a shorter amount of time. But weigh your pros and cons as far as implementing the exercises. And that's it. Thank you, guys.
Do you guys have any questions for Rashad? If not, he will be leading a breakout session at about 10:30. So if you guys.
Okay. Oh, you can hear me. Dang it. All right. I'm just the guy you do not want to listen to. I know that. Let me get this out of the way here. That'll work. All right. So I'm going to talk to you today about a new way to look at an old issue, a paradigm shift in ACL rehabilitation. Bob helped me with the title. I'm not smart enough to think of the word paradigm, and I had to look it up to put it on the slide. But basically, the genesis of this whole idea of this whole talk goes back to when I worked for Dr. Lowe. And so when I was there, it never failed. A little early there. You get a phone call when I worked for him, and somebody said, "Hey, my kid just saw Dr. Lowe, and he's 12 weeks out, and he won't let him jog, and the protocol says he can jog." Well, okay, let's step away from the cliff. Let's look at it. So you'd say, well, what is their motion? Well, they lack a little bit of extension. Well, what's a little bit? Oh, about 5 degrees. Okay. Are they swollen? Yeah. Can they walk without a limp? Well, no. And you want them to jog? Well, the protocol says. All right. So no, we can't do that. So I go to Kingwood Park. No, I didn't get fired. We've talked about this before. So when I was at Kingwood Park, I just said, basically, if they weren't ready, you weren't ready, shut up. I don't look at the protocol and stay off the internet. That was the worst one. Well, the internet says this. No. All right. So now I come to Memorial Hermann and I get the same phone calls again. Well, hey, Dr. Crumbie won't let my kid jog, or Dr. So-and-so won't let him jog. And you're like, so it's like, all right, it's time. I had this talk with Dr. Lowe when I worked for him, and we kind of tabled it, and now it's back. So what are my issues with protocols? Okay, they're not a cookbook. We don't follow the steps, okay? We don't have to have just this much of one ingredient or the other. It's a guideline. Plain and simple, it's a guideline. We should be able to do these things within this reasonable amount of time. Okay, many therapists, athletic trainers, and physicians only follow the cookbook, and that's wrong, okay? Everybody is individualized. Everybody's a little different, okay? Not all are going to jog at 12, jump at 16 to 20, and be full go at 20 to 26 weeks. It just doesn't happen. We know that, but yet we get into that rut of following along, okay? So what's a normal progression? 6 months? No, that's Adrian Peterson. That's the man-child. Our kids aren't ready at 6 months. Many college and professional athletes are not ready at 6 months. But everybody says, at 6 months, I'm going to go. How many kids do you get to go out there that get cleared at 6 months and the coach kicks them out of the drill for the next 2 because they're in the way? Happens all the time. Okay, 12 months, that's the outlier on the other side. Those are Navarro Bowman's, those multi-ligament injuries, and those other things. Okay, the failure to thrives, that's the FTTs and the P3s, which are piss poor protoplasm. You're bad athletes that get an ACL tear that you're stuck with forever because they're not going to come back anytime quickly. Okay, everybody else falls within about 9 months. Okay, that's your normal rehabbers now. Your Gronkowskis and those, they're 9 months. That's his job, and it takes him 9 months to come back from an ACL tear. But everybody thinks they're Adrian Peterson. How hard is it to get a kid to come into the training room or the clinic on their scheduled times during a week? Adrian Peterson did it 6 days a week. But I want to go on a date. Well, he had a kid. Then we won't get there, but and other things, all right? So I want to do a criteria-based protocol. Basically, there's not any out there, really. Paulo's talked about it. The Nutty Professor, if you know him, he's crazy. He's a brilliant man. But he talked about it in 81 based off of minimum time frames and specific goals of each phrase. But there's really nothing out there that's real specific. Adams out of Delaware in 96 and again in 2012 came out with one, but it's not a true criteria-based protocol. It still has weeks involved. So we'll say, well, you need to do these things, but in 12 weeks we can do this. Well, that doesn't follow what I'm looking at trying to do. And then Wilk, who everybody knows in 99 and again in 12, talks about it's kind of got weeks in there, but he only really talks about the end stage and the return to play. Well, you need to be able to do these things to return to play. Well, what things do we need to do to be able to jog or to get off our crutches? What do we need to do to be able to go from jogging to jumping? It's not out there, and hopefully we've come up with it. And then Myers in 06 came up with return to play criteria as well, but again, nothing in the early stages. So I'm old school, okay? Just like education used to be. If you do the work satisfactorily, you advance a grade. No seat time, okay? You don't do the work, you repeat the grade, right? There's the no seat time. So we do not advance just because we're at that post-op week, okay? We're ready when we're ready. When is that? When you're ready. So there's 150 to 200,000 ACL surgeries a year, okay? Are we doing those patients a disservice with our current protocols and the way we, not the protocol, but how we utilize that protocol? My answer is yes. Just mine. I can't speak for anybody else. Are we harming our professions if we do that? The answer is yes. My opinion only. You can disagree, that's fine. Okay? And ultimately, here's what it goes down to. What's best for the patients as far as rehab and return to play? Do they need to be at 6 months? Some might. Do they need to be at 12 months? Some might. Do they need to be in the middle or somewhere skewed off that line somewhere or the other? And the answer is yes. We should individualize this. Okay? You're ready when you're ready. So off that protocol, each phase has criteria that must be met before advancing. So it's a check sheet. And if let's just say, for instance, it's 5 boxes, if you've got 4 out of 5, you're not ready to go to the next level yet. Once we meet that 5th, we would move on. Okay, it's based on published research, so it's not just something we pulled out of a thin air and said, hey, this is cool, let's put it in there. Okay, and biological healing is taken into consideration. That's the MD checkbox on this protocol. Okay, what graft did you have? All those are going to play a part, and we're going to talk about that. So tissue healing matters. Okay, BTB, hamstring, those things, the graft type, how the fixation went. Sometimes that surgeon gets it in there and goes, I just don't like how that bone felt. We need to slow them down. That's based off that physician aspect of this. Okay, what if they have other ligamentous injuries? What if you're an ACL, MCL, and a lateral meniscus tear? Do we rehab the same way we rehab if we're just an isolated ACL? No. Our time is longer to get better. That's common sense, but that flies out the window sometimes. Okay, and our meniscus, just a straight meniscal repair even could go through this. Microfracture. We can do this, a lot of the rehab exercises in the protective phase following a microfracture, but if you have that in relation to an ACL, that changes the ballgame. So what's normal rehab? Okay, again, our tissue healing. What's our weight-bearing restrictions? What's our range of motion restrictions? Okay, those are all there. And I'll talk about it in a second, but our first phase, that's your MD checkbox. What do you get? You get a protocol that says ACL reconstruction using patellar tendon graft. Weight bearing is tolerated, progress to full, 0 to 60 on the CPM if they're using it, and go. Well, progress to full. That's our, and that motion, that's our physician checkbox right there. They've told us what they're going to allow them to do. So we know, we know when they can get off crutches at that point. Okay, so we can use this for ACLs. We can use it for multi-ligaments. We can use it for meniscal tears, meniscal repairs. Patellofemoral issues are our ACL rehabs and our patellofemoral rehabs, in essence, not one and the same for the most part. We're still protecting, right? Okay, collateral ligaments, chondral defects. Nothing changes in all of those. Those are not 1, 2, 3, 4, 5. Those are not 6 different protocols. It can be one protocol, in my opinion. We do them all relatively the same way. So let's look at the criteria specifically, okay? Again, it's got to be published information that we're using, validated, okay? We want to have widespread use and understanding of the test or the criteria that we're involved with, okay? That's in a nutshell. So phase 1 and phase 2 are the acute and functional phase, and those can be, they're asterisk for a reason. Those can be put into one. Basically, that acute is right after surgery to the functional, which is when they're off crutches, okay, where they can function, they can ambulate. That's one phase, really. Okay, kind of a unilateral strength phase, a return to sports phase, that's kind of, our off-season stuff, and then a return to play where they're fully fired and they can get out there and go do whatever. So what are our goals in those, okay? In that first phase, it's basically full amputation without an assistive device. Phase 2 is a jogging program, and I did give you handouts this year, so most of it's the same as to what I'm presenting. Your phase 3 is agility training, and then full clearance, okay? So what do we got to do in phase 1 to get off of our crutches and out of the brace? Well, the visual analog scale, we want it to be less than or equal to 5 when you grade it out. Most people are familiar with that. What's your pain scale? 0 to 10. 0 is nothing. 10 is shoot me and I'd feel better. 5 or less, okay? Your IKDC, which is an International Knee Documentation Committee score, we want it to be greater than or equal to 30. All that'll be in our protocol as we take care of this, but you're going to have these kids fill out a questionnaire. And this is a validated questionnaire that does a real good job of looking at kind of how they think they're doing. We want our extension, passive range of motion, greater than or equal to 0. At least 0, no extension lag. Okay, and if this kid's got 10 degrees of hyperextension, we're not looking to get 10 degrees of hyperextension on that surgical leg. Okay, but we want 0 as our minimum. Okay, On your flexion, at least 90, more like 110. 110 gets us on a bike, okay, but at least 90. All right, and then they need to be able to do 30 straight leg raises without getting an extension lag. Okay, not just 5 or 6, but 30. And then your balance error scoring system, we're all familiar with that. We're going to do it straight, single leg on a firm surface, less than 5 errors. Okay. And then your MD clearance, which we said is off of what your range of motion and weight bearing is. So if they advance to those, okay, now we're going to the next phase. We're going to talk a little bit about some of these criteria that they have to meet. So we're all, again, visual analog scale 0 to 10. All right, IKDC. It's the International D-Documentation Committee. That's what it is. And what this does real well, and again, this is validated in research, identifies athletes who fail to return to play up to 1 year after ACL reconstruction. So by them filling this out, we get a good idea of where they're at and how they're doing. Okay? Range of motion. We obviously know this, but we're going to talk a little bit. Loss of 3 to 5 degrees of knee extension or hyperextension adversely affects the subjective and objective post-surgical results. Shelbourne talked about that in 09. Okay. Osteoarthritis is lower than those that achieve and maintain their range of motion. Our joint stresses are different when we have full motion. Okay. So in our unilateral strength phase, what do we got to do to start jogging? So we're off our crutches and our brace, but we're not ready to go. We're not ready to do much else. We're strengthening here. Okay. But to be able to jog, our visual analog score comes back less than 3, equal to or less than 3. Okay, our IKDC greater to 60 now. All right, our motion is still 0 or better with symmetry. Okay, again, they got 10 degrees on that other side. We're not looking for that, but at least that's 0. 120 degrees of flexion now. So overhead squat, if you do the functional movement screen, you want them to grade out at greater than or equal to a 2 at least. Okay, and most of us are familiar with some aspect of that. And then we're going to do a minute of single leg squats, and we're going to make sure that they can control that leg. And our physician's got to tell us it's okay to start jogging. They're probably going to go back to the doctor at some point where he's going to, depending on who they see, take the x-rays, look at everything, and let them know. Okay? So we talked about some of the others, but if we look at just the functional movement screen for the overhead squat, it's graded from 0 to 3 based off of their technique. Okay, any pain, the athlete gets a 0. All right, this hurts. You got a 0. Doesn't matter how good it looked. There's pain. Okay, so what you see here is kind of a good one and not so good, especially if you go down here to the bottom right. The F right there is most of our high school kids squat, if you can see that. All right, so we're going to do single leg squat test. That's for the minute. All right, you can see a good squat here, and we progressively get worse over there. That's what we're grading. Okay, if they look like C and D, for sure they're not ready, and if they look like B, depends, but if they look like A and they can do that for a minute, we're golden on that. We check the box. Okay. It's all part of the Vail Sports Test. And basically, it's a reliable measure of physical performance following ACL. We know if we can control this, we're ahead of the game, right? We're not dropping into that valgus. Our hip's not dropping. We've got strength and we've got control. That's a good thing. Okay, so here's kind of the single leg squat test. There's some other aspects of that we don't use early. Some lateral motion, some forward and some backward work that you could utilize too, but we're just looking at single leg squat. All right, so phase 3, our kind of return to sports, that's kind of our off season again. When can we start doing agility work? Well, pretty simple. You notice there's a lot of things that we're doing every phase to look at. Visual analog now is less than 2. Okay, all right, KDC is up to 70 now, what we need it to be. There's something called the Tampa Kinesiophobia Scale, and that's really looking at mentally, are they afraid? How are they doing? It's another worksheet. We want it to be less than 20. And then we're going to look at heel height difference. And Ryan in his talk is going to talk about this. He's going to piggyback some of what I'm talking about today. He's one of the people that's been working with me on this. We want less than or equal to 1 centimeter of difference, because you can have a difference. What if they had an ACL on the other leg too? Okay, so there's a symmetry is what we're talking about. And then quad strength symmetry of at least 80%. We know that most clinics don't have a isokinetic testing device. None of the athletic training rooms do, and very few athletic training rooms have a handheld dynamometer. We're not saying you got to go buy one. We're looking at some options for that to look at this symmetry. There are some things we're working on that's kind of cool, and then I'm looking at a low-tech redneck approach that I'm going to mess around with this summer to see if that works. Okay, Y balance test. We want less than 4 centimeters deficit when we do Y balance. And if you know, Y balance is basically the paired down star excursion test, for those of you that are familiar with that. Okay, landing error scoring system, less than or equal to 5. And then MD approval. Okay, let's look at some of these. Tampa scale. It compares physical impairment, functional, and psychosocial measures based on fear of re-injury or lack of confidence and the return to sports status after surgery. And this is published by Lentz, AJSM in 2014. So again, it's validated, it's published, it's researched. So our quad and hamstring strength ratios. Post ACL with a weak quad, we demonstrate altered landing patterns. That makes sense, doesn't it? Okay, if we're not strong enough to begin this, why aren't we doing it? We're setting them up to fail. Let's make sure they can do it. We also know that if at least 90% their functional performance was similar to the uninjured. Y balance, all right. Anterior right-left reach, distance greater than 4, we're 2.5 times more likely to sustain a lower extremity injury. Girls with a composite reach distance of less than 94 of their limb length were increased by 6.5 times. Okay, and should have some pictures on here to kind of show you this. So this is the device, and basically you're standing on the platform and pushing out with your foot, pushing back, and then coming across, and it's measurable. We can look at those distances and count them. This is the old star excursion. So here we go, going anterior, okay, just like that. So landing error scoring system, valid for identifying high-risk movement patterns during the jump landing task. Very few people get in trouble going up. We get in trouble coming down. Okay. Alter control of the hip and knee during a dynamic landing task after ACL reconstruction are a predictor of a second ACL injury. So again, if we can't function, why are we allowing them to do it? Just because the protocol says it's that time frame that they can do it. All right. And then patients had worse landing. We know that coming back from ACL surgery, those patients have worse landing mechanics. Makes sense. Let's work on those. So here we go. We're looking at them coming off a box and landing, and then we have them go vertical. You don't necessarily have to, but you want to be able to look at them from the side and straight forward to see if we're going into valgus, if we're landing too upright, or those things. And we have all those that we're creating into a binder that'll have how to grade it and a score sheet for that. We're trying to make this simple. So phase 4, full return to sport. All right. What do we got to do? And some of this is, I got a bunch of them, so the print's a little small. VAS 2. All right. AKDC is at least 80. Tampa 20. Heel height difference stays the same at 1. Our symmetry is now to 90%. Okay. As close as we can get to that 100, the better. Quad strength, quad ham symmetry is 55%. All right. And symmetry for hop testing, so we're going to add the hop test in here. And then agility test, the T-test and the figure of 8 test, which we're all really familiar with. Those are in there. And again, we got to do sports metrics at this point. We've got to complete it. We cannot be in week 3 of sports metrics and be cleared. We have to go through all 6 weeks of sports metrics, in our opinion, before we can be cleared for full participation. And your doctor's in there in that last checkbox. So all of these would be a checkbox on your sheet. Okay, Bubba, you've got 7 of 8. You're not ready to go. Or maybe the 8th one is doctor. They've got all the criteria met other than your approval. That's pretty simple for the physician to make a decision at that point. Or I could have 6 of 8 with one of those being a physician. The physician can come back and say, when you get this box checked, you're free to go to the next criteria, or free to be fired, or whatever it is. It's pretty simple, in my opinion. So let's look at single leg hop test. The research on it, conducted over 6 months, or 6 months after ACL, can predict the likelihood of successful and unsuccessful outcome at a year. Okay? So we're doing a total distance single leg hop. We've all pretty much are familiar with this. The total distance crossover and a 6-meter timed. Okay? Agility test. So, reliable for subjects in a team environment. We want them at 90% or better. Here's our T test. 10 meters forward, 5 lateral each way, and then a figure of 8 test. Okay? These are pretty standard. We've all done something similar to this with our athletes. We just never really put it into a criteria or graded it as much. And then we all should be familiar with sports metrics. So sports metrics and is an intervention training program, positive influence on injury reduction and athletic performance. So we know with sports metrics, we can take ACL tears in females that are 6 times at least compared to males and drop it to 2 to 1. So why wouldn't we be utilizing something like this in stage before we go back to athletics? And from a mental standpoint, if I can do sports metrics, I can go back out on the football field, the basketball court, the soccer field, or wherever it is. So this is kind of our pre-testing of sports metrics. If you see them on takeoff, they really got that valgus look. Okay? So what's my plan for this? Well, what are we going to do with it? Well, it's this today. It's to talk about it. Okay, we want to publish it. There's nothing out there published about a true criteria-based protocol for all stages. So we want to publish this. That's what we're working on right now. I'm not smart enough to write it up, but I'm good enough to hopefully get my name on it. All right, it was my idea. We want our UT physicians to utilize the protocol. I talked to Dr. Lowe this morning. I want him to do this with it. He's going to bless it, and he's going to tell all the physicians this is what we're going to utilize. Okay? We're going to start with some of our Memorial Hermann clinics, and we're going to start using this and collecting data from it. All right? Then we're going to teach other therapists, and we're going to try to publish that data. We think it's going to work, but we don't know. We got to collect data on this and look at it and see, is this good for the patient? Is this doing what we think it's going to do, which is, and Crumby's going to talk a little bit about this tomorrow, but are we going to hopefully try to decrease that number of revision ACL surgeries from a re-tear? Not because of a graft placement issue or whatever, but because they were not ready physically and mentally to go back. That's the idea. That's all I got. Thank you. And shockingly, I was on time.
Okay, folks, my name is Mike Barr. I'm pleased to introduce our next speaker. This is James Casey Callahan. We kind of go back. We were workmates together at Richmond Bone and Joint Clinic before they were bought by Memorial Hermann Sports Medicine, and they transitioned over to ET Physicians. But Memorial Hermann kept the better part, so they have the rehab area. Casey's a certified hand specialist. Good guy. He also is going to have one of the breakout sessions here right after here. You know what? There's so much to say. He's just a good guy, hard worker, knows his stuff. I'll tell you that. And when we get out into the breakout session, I think you'll understand a lot about more. So I don't want to drag it all out, but I'll let my young friend here do his thing. Casey? Oh, Casey, can you turn your mic on? Top button. Gray on.
How's that, John? All right, there we go. So I cover two facilities. I cover our Sugar Lake facility, which is at the corner of Williams Trace and 59, and also Richmond as well. Okay, no conflicts of interest. Since I am the only occupational therapist and hand therapist presenting, I just wanted to give you a brief background on what the requirements are in order to become each one of those. So for occupational therapists, it is a master's level program, and you have to pass a national credentialing exam by the National Board of Certification of Occupational Therapy. We're licensed by the state of Texas, have to meet all of those requirements, and we're allowed, once we have met the requirements, we can practice in all of the usual settings. Also, for certified hand therapy, it is a national certification. Only someone who has passed the test and met the requirements is able to have CHT behind their name. So it can be an OT or PT, but you have to have at least 4,000 hours of documented upper extremity rehab treatment, pass the national exam. You have to maintain and recertify every 5 years. 85% of all CHTs are OT, and then PT, and on down the line. What is good about this is that if you ever do have to refer to somebody, make sure they have the CHT behind their name. Now, even though it says certified hand therapist, we treat more than the hand. The exam literally goes from neck down to the hand, but within my practice, I see some shoulder, but for the most part, mid-humerus down. So some common statements regarding digital and hand injuries. A lot of times, unfortunately, it does get dismissed. A lot of times, I've only hurt my finger, I just jammed it, I just twisted it, no big deal. But I always like to say there's a whole lot more than meets the eye when it comes to the hand. So you have something right here, ring finger ecchymosis, doesn't look to be too bad, but then they see the doc and it turns out to be this. Another example, common PIP injury. Oh, I just twisted it, just jammed it, no big deal. You see the doc, get a film, turns out to be this. So again, there's much more to a finger than meets the eye. If you look at a finger, it doesn't look terribly impressive. Little skin, bone, no big deal. But just this right here is just one aspect of a finger. Netter picture, you have the top portion, extensor apparatus, sagittal, you get to see extensor and flexor, and on down the line. And even this doesn't do it justice. There's no skin, there are no vessels, no nerve, no pulley system. Go a little bit deeper, there's even more than meets the eye. nerves working the way through, pulley system for the fingers, thenar eminence, hypothenar. You say, well, it's not that big of a deal. I can still move it. There's still some function to it. But in just the hand, 29 major minor bones, 29 joints, 123 ligaments, 35 muscles, and on down the line. So all of that is within about a 6-inch span of your hand. So a lot of times you have an athlete with an injured digit, injured thumb. It's not that big of a deal. You know, should be able to work through it. So a quick example of this is just to show you how difficult it can be is that if you just hold up your hand and just hold any finger you want, I'm going to just hold the index, and just hold that one finger. Now try making a fist. It's impossible. You can't do it. So what I did was to show you the value of one finger and one thumb. We did a JMAR test, and literally, as soon as I turned this in the Journal of Hand Surgery, there's a study that came out showing that just one P3 injury, you lose at least 10% of grip strength. So the standard setting is on number 2, and I just did a before and after test. You working here? There we go. Value of just one digit. So finger injury. Top picture, full grip, all digits, 50 pounds of grip strength. Extend one digit, drops down to 30. So with just one finger injury, 20-pound loss of grip, 40% decrease. Thumb, same thing, 50 pounds, remove the thumb, 50% decrease. Went from 50 pounds of grip down to 25. Now, having said that, with that being the case, do you trust any of your athletes to not only perform, but perform well? And do you expect them to do these things safely? I'd say it would be pretty difficult. So this morning, I'm going to go over some common injuries to the hand. We're going to go digits. Whenever we talk about digits, it's literally the fingers and thumb themselves, and the hand is usually metacarpal area. So I'm going to go over mallet, boutonniere, jersey, PIP, phalangeal fractures, thumb, and then metacarpal. All right, first, mallet injury. This is how it will present to you. So the digit will be in PIP flexion. They will not be able to actively extend. Now, if you push on it and you say fire, you can use some of the extensor apparatus where they can maybe hold it, but for the most part, if you have them flex and extend, they will not be able to extend. They will be stuck down. May or may not be painful. I've had some that they literally could not feel a thing. No signs of injury. They were just doing something, popped, and they come in like this. So if it's an acute injury, you'll be able to passively extend, straighten it easily. If it's something more chronic, you can push on and it will not move. All right, so the mechanism of injury and the pathomechanics, it is a forced flexion of an extended digit. So a lot of times there'll be a ball hitting the fingertip. Sometimes it can also be a loaded mechanism like this. I've had a number of injured patients who were just playing around, were flicking people. They loaded up, pop, and next thing you know, they come in with a mallet because they pop their extensor tendon doing so. It is a tendon injury. Sometimes it does require surgery. And there can be just a tendon pop, or sometimes it can, so right there, just a tendon avulsion. But sometimes right here, you'll also get a bony aspect. So the medical treatment is that the DIP is in neutral to a very slight hyperextension, only about 10 degrees. Cannot go too far because if you do that, your skin begins to blanch and you can lead to necrosis. 24/7, anywhere from 6 to 8 weeks without fail. If they take it off and start to experiment, the clock starts all over again, and all they do is put themselves at risk for having to have surgery because they keep re-injuring the tendon. So once healed, the doc will begin light motion and also transition to nighttime use. So the orthosis management, I'll have pictures of that in just a second. You have to maintain the correct position of the digit. PIP remains free. That is important because a lot of times patients will come in because they've been placed in something where it blocks their joint motion. Next thing you know, instead of them just having a DIP injury, they now come in for PIP stiffness as well. There's no, all the studies show there's no one technique that works best, but custom is best. But custom orthoses are best. So many different examples of, so you have the common stack splint and on down the line with the Lumiform. But this is the most common one that I make. So as you can see, right through here, the PIP is free. You have a volar dorsal. You can see the angle that puts them into neutral to slight hyperextension. And I have them supinated to where you can see that the PIP is free. And back one. There we go. So have an athlete come in, and so this right here is the way that I like to immobilize them. I use Zonas tape to connect the skin to the orthosis. So as you can see, full PIP flexion. But also this brown tape is also kinesio. So I like doing that, especially if they're going to be out playing and they're going to sweat a lot. So that way the digit will not slip at all. And the rehab aspect of it, the doc will allow you to begin motion, usually right about 6 weeks. And you just start off with light blocking exercises and DIP motion. But with this, just to have you think about it, as soon as someone comes out and you have the doctor's order and they say, okay, begin range of motion, what is something that you do not want to do with this patient population? Exactly. You do not want to have passive DIP flexion. That is a guaranteed way of popping the tendon or giving them a slight lag. So light active motion, no passive motion. That's right here, just examples of standard exercises. So straight fist going to a hook. So start straight, have them fire down, and then lightly to a full fist, straight, hook, full fist. And then after a few weeks, if they're still a little tight, you can begin with light blocking of the DIP and also for IP flexion. All right, next, boutonniere injury. This is the way that they'll present. Hyperextension, PIP flexion, DIP hyperextension. So, so as you can see, PIP flexion with DIP hyperextension. Motion is limited in both directions, but primarily to extension. Again, just like with the mallet in chronic cases, if they've been like that for a while, if you try immobilizing them, you will not be able to get them straight. A good test for this is the Elson's test. Pretty easy to remember because you put them down in this position, looks a little bit like an L. And then from here, you would say straighten. If you have them fire as hard as they can, but it doesn't feel like there's anything there, then they've popped the tendon. If you can feel some resistance, then you can feel confident that the tendon is intact. So the mechanism of injury, It's a zone 3 tendon injury, and this happens in much the same way as the mallet. A lot of times it is a traumatic blow, but as you can see right here, this is what happens. You have the zones of the extensor tendon, 1, 2, 3. So right there of the PIP, the tendon pops, and there is the assumption of the position with the hyperextension, flexion, and hyperextension. So with this type of injury, what do you think is a common injury that would put you in this position anyway? Yeah. Most any type of PIP injury, especially a dislocation, because as you can see right through here, if it goes up, down, that right there over the PIP area, the extensor tendon is compromised. So medical treatment, mobilize full extension, DIP. You want to have somewhat immobilized, but you want to make sure that the MP is free, and full-time immobilization, and sometimes it can be a tendon repair. So the orthosis management, just like I said, full PIP extension. You want to have the DIP somewhat immobilized so they don't begin to droop down, and MP is free. So here's an example of what I would make. So as you can see, you want to keep the digit in full extension. So you have the volar dorsal aspect right here, and you can see that the MP is allowed to be free. Right here, they can remove that in order to do the DIP exercises, which are allowed. They do not have to stay completely immobilized. That will prevent any further tissue tightness. And through here, I go with the strap so it's easily removed. And the rehab, based on the doc's exam, usually anywhere from 4 to 6 weeks out, they can begin motion. But with this, what motion do you want to avoid as soon as they come out? They say, okay, begin range of motion. What do you not want to do? Do not want to go into full flexion. You do not want to stress the PIP area because you're putting maximum stress on the injured tendon. So what we do for this condition is you want to start with graded active motion. So with this, you start at anywhere from 20 to 30 degrees motion, put a goniometer on them, measure it, bend the lumiform. That way they can safely begin to perform active motion without stressing the tendon. So right here, full extension, which they're allowed, and go down and just back and forth. And as the weeks go by, you can bend an extra 5 to 10 degrees to gradually have them come down toward full IP flexion. Jersey finger. So first we talked about the extensor tendon injuries. Now we're getting into our first flexor. So the digit rests in full extension or in more extension as compared to the other digits, as you can see right here. Natural resting hand posture is every digit slightly flexed with an ulnar drift. As you can see, ring finger completely extended. Also, it is unable to fully flex and perform a full fist as the other digits. And a quick test for that is one, just visual, but also a blocking test where you hold the digit in full extension, hold volar dorsal, and have them try to fire the DIP area. If they're not able to fire, then you can count that they have a Jersey finger or an FTP injury. So unlike the mallet where it was a trauma to extension, here it is a trauma from flexion toward extension. So as you can see over here with the football player right there, this athlete did wind up having a Jersey finger because as he pulled away, full flexion, and then resisted extension. And also an interesting fact is that about 75% of the injuries are of the ring finger. So as you can see through here, and if you block yourself just right, you can see that the ring finger extends about 5 millimeters farther than the others. So it is the most common finger for a Jersey finger. This condition right here is only fixed by surgery. You cannot rehab this. You cannot splint this. The only way it can be repaired is with surgery, and it truly needs to be done by a true hand surgeon who does this on a regular basis. And if you have any suspicion of this at all, get them in, because the quicker you repair a tendon, the better the outcome. And as for the rehab aspect, this really needs to be treated by a hand therapist who works closely with a hand surgeon, because the protocols in the rehab for this are based on specialized orthotics, specialized exercises. So you really do not want to have someone who does not have the credentials of CHD behind their name treating this, because if not, you're almost looking for a rupture. Okay. Move on to PIP sprains, strains. So as you can see, it is usually, it's always a VIP joint, a diminished joint. Usually you can count on one side being larger than the other. And the digit is usually in a flex position, ecchymosis, and with limited active range. So as you can see right here, sliding into a base here, and also a more acute picture there. So the PIP, zone 3, extensor tendon, as you can see right through there. And what makes this especially troublesome is that you have so many structures within a very small area. You have the extensor apparatus, you have your flexor system, you have the collateral ligaments, so you have all of this in one area. So really don't look at this as just a PIP injury. Look at this as an elbow, look at this as a knee, because the elbow, knee, and PIP in all studies, they all trade places of which joint is the most difficult to rehab or to regain full motion. So the injuries can go volodorsal. We're going to just focus on the dorsal because the dorsal is the most common. So as you can see, the P2, P3 are dorsal in respect to P1. So with this injury, you not only can get ligament tears, but also you can get fractures. So the more of the bone that you have fractured, the more unstable the area becomes. Also with this injury, you can have a lot of instability because of the volar plate. That keeps you from going into hyperextension and keeps the joint steady. A lot of times that can be injured. So with this medical management, if it's stable, less than 10% of the surface being injured, rest for a few days, begin to buddy tape. Stable with a fracture, 30% less. You can go with a light dorsal blocking that keeps them in slight flexion. Unstable, surgery. So with this, as I said in the last slide, how you want to keep the joint, keep the PIP in anywhere from 10 to 30 degrees of flexion. That is important because they were injured this way. You do not want to stress those structures, so you want to keep them in very slight flexion. The higher the number, the more unstable the joint was. So if you're on the low end, you had a pretty stable joint. So as you can see, this is something I'd make. Slight flexion, and I'll go dorsal on this to prevent them going into full extension, but also it allows them active motion. So that was the dorsal dislocation. This right here is a lateral sprain. What's especially troublesome with these is the aspect of the rotational component, because as you rotate, you can tear the collateral, but also you can get a fragment and get a fracture with it as well. So if it's stable, buddy tape, begin motion. Unstable, fracture, again goes to surgery. So some different buddy taping techniques that you can go with depending on how much stability that you need. This is my favorite version right here because the Coban will stick the digits together. It helps with the swelling, and then you go on top with the Zonus so they move with a nice uniform motion, and they're completely locked together, and really makes a nice stable finger. Where I've noticed that with this technique, it can slip and slide, and here the motion is usually very unbalanced. So as you can see, completely immobilized, and you get a nice full flexion and extension. So if you have a lateral injury, this is an orthosis that can be made for. So as you can see right here, MP, PIP, DIP are left free, but the mid portion is completely immobilized, full MP flexion, and also allows DIP motion. And what's great about that is that you can buddy tape that, you can have helmets, you can have most anything hit them, and the middle joint will not move. And with the rehab, again, motion as doc allows. You do not want any stresses to the area, so no testing to see if they can turn this way, that way. Nice, easy, straight ahead motion. And with this, what is the most dangerous activity for them to perform? It'd be anything with a twisting motion. So flex bars, trying to squeeze towels, anything that puts a lateral twist on that. You do not want to have anything in the hand. You want to just begin active motion without any resistance. So there are many different phalangeal fractures that you have. You have P1, P2, P3. Just for the purpose of this, we're just going to stick with P1, since P1 is the most common injury. So you have many different fracture types. Again, with this, along with the lateral PIP injury that we saw, the most damaging part of this, and what you really want to keep an eye out for, is the rotation of the digit. So just some examples of fixation. So obviously, the more hardware, the more serious the injury was. So with this, you can have them depending on the severity of the injury, on what the doc would allow. Sometimes if it's very unstable, you'll have something that will cross the wrist. If they're more stable, you have them hand-based, but as you see in both pictures, the MPs are flexed because that position puts less stress on P1. So no matter what, you do not want to have them in full extension. You want to have them in slight MP flexion. So with these P1 injuries, flexion and extension, both of them are difficult to achieve, but just like with the knee and elbow, anything crossing the PIP, you can almost guarantee they're going to have difficulty with extension. So this is a quick test that you can have with your athletes, to where, again, with this injury, the most common side effect, but also the most damaging side effect, is rotation. So quick way to monitor that, either acute or post-acute, is light, easy motion, where make sure they don't sandwich together, because you can block the rotation. Is do that, just a little bit of daylight, and just have them fire down and then come up. So if you begin to see rotation, get them to the doc right away. If you don't trust the way they're moving, you just hold forearm and extension, squeeze about midway. So if you see me right here, squeeze, you're going to nice even flexion of the flexors. And that way you can also see if you have any type of rotation. Okay, so we're going to next with the thumb injury. UCL, very common injury with the digit. You have the UCL test. As you can see, put the MP in about 30 degrees of flexion, light radial based stress. If you hit an endpoint, they're intact. If it just keeps going, or you hear a click or a pop, then they have injured the UCL region. So again, much like the mallet injury, it is something usually that is stationary and the athlete is moving. A lot of times it can be with a pole or bat or a device, or sometimes just a fall here. So as you can see, baseball player here hitting bag, UCL injury. So medical management, if they're stable, immobilized for a few weeks and then go from there. They're unstable or they have a Sterner's lesion. The only thing I will fix that is surgery. This right here is an orthosis that I make for many athletes, but I have the picture of the baby right there with the explanation that you do not have to use the biggest, thickest material that you have. You do not have to block them down in order for them to be stable. What's most important is layers. So if you're going to stay warm, you layer up, and if you want strength, you go with layers. So I have the pre-wrap, the orthosis, tape, and then follow that up with Coban. I promise. And as you can see right there, full motion, but they will not be able to move the MP region. There we go. Next is the metacarpal. So you can see right here, telltale sign, big lump, rotation, also limited motion. Also another test is if the knuckle is gone, you can guarantee that the metacarpal is shortened, but you always look for this right here, nice rotation all the way down, and you always want to see knuckles. You'll always have a dorsal aspect to it because of the pull of the intrinsics right through here, so that's why you always have a dorsal aspect. So conservative casting, 3 to 6 weeks. More unstable, you go to surgery. So sometimes this can be over the wrist or even hand-based, depending on how stable it is. But through here, this one is over the wrist, dorsal-based. And what's important is that you have the dorsal hood there so they do not begin to fire, but also it keeps the digit from rotating and also keeps them from developing droopy fingers. And this right here is an example of a playing orthosis that I have. So this right here, third metacarpal fracture, put a piece of padding, orthoplast on top, pad. And again, the same aspect with this. You don't need to put the heaviest material on them. Something light, but layer it up. Pre-wrap, Coban, as you can see, third metacarpal is fully protected, but they still have full flexion. And with this, the most common side effect or the most difficult aspect of this would be what to gain based on this picture. What do you think would be most difficult to achieve based on this? A lot of times it's going to be digital extension. Right here, because as you can see, the EDC is very intimate with the skin and the two scar down very easily together. So extension, not flexion, is going to be what's most difficult to achieve. Just examples of exercises. Get back to the last couple. Yeah. Anyway, so with the motion, easy way to achieve full extension is going to wrist extension, because as you go into flexion, the digits naturally extend. So come here, fire up, easy, safe way to regain digital extension. And there's, toward the end, you'll see a study, something from Hand Pearls from the Journal of Hand Surgery, where it says the most devastating aspect of digital injuries is stiffness, that they can put things back together, but the scarring, the adhesions, and the stiffness after the fact are the most common, and also the most devastating aspects of the hand rehab, and also with hand injuries. So I have breakout session where I'll be making the orthoses on whomever would like one. In the breakout session, I brought some of my eval tools with me and answer any questions or make anything else that you like. I have a modified splinting area for y'all, so you can take some demos away with you if you like. Thank you very much.
Any questions for Casey?
Thank you, Casey. We'll let you go to your little
All right, thank
room. Now we're ready to break up into our breakout sessions. We've got 4. Rashad Ford will have one back in the back corner, and there will be people out there in blue shirts to help you find directions. Casey will be in the end of that hallway. Chris Juno will be here with dry needling. And Ryan Collins, who just recently passed his SCS, will be in this room right across in the foyer. We'll go about 25 minutes in each session, then we'll kick you out of that room and you go to the next one. We'll rotate through. Lunch will start being served about noon, and we'll start going and kind of shift a group out of there towards lunch. All right? For those of you that are new this year to this location, we'll help escort you. Brad Cooper and a bunch of us will help escort you to the lunchroom or the cafeteria where we'll eat. And I don't know what we have on the menu today, but Brad always picks something pretty special. Too special for my palate. So at this point, we'll let you break up and break off into those other breakout sessions.
Test. What's that? Oh, sorry. Okay.
Hey, Chris, just wait just a second. I've got to get the adapter for, it's not working for some reason.
This thing is. All right. Well, thanks for coming. This is this is quite a crowd, so this will be great. So what we're going to talk about is dry needling. A couple of disclosures from my end. I do, as of recent, if I can get this thing to work out for me, I am in training for faculty with Kineticor, which is a certification organization. So most of Memorial Hermann, the courses they brought in is through spinal manipulation and Jeff Dunning's group. This is just a different course and a different organization, and that's who I'm with. So what is it? And this is changing rapidly, if you will. But the national board, I'm just going to do this. The national board has kind of identified it as a manual therapy procedure that that intends to puncture the skin to identify and release soft tissue pathology. Most notably, using a solid filament needle to insert through the skin and local trigger points for areas of high nociception and sometimes failed healing. As far as who can do this, most of the courses throughout the country are identified as physical therapists. Most courses are directed towards physical therapists. There is some change right now with PTAs that are they're lobbying in that department. They're not currently able to do so. ATCs in some states they are actually licensed, or I say licensed, certified to do such. You'd have to check with your own independent states. As far as licensed massage therapists, not at this time due to the fact that they are not allowed to penetrate the dermis in a lot of their practice acts. Acupuncturists, yes, obviously they can perform dry needling, and then chiropractic, yes, as well. But again, the intention is for treatment for pain relief, improving soft tissue extensibility, and a few other things that we'll cover here in a sec. So what it is not, this is a huge problem right now within the national organization, being that acupuncturists are actively fighting back, and for good reason. It does very much appear to be acupuncture. It uses the same needles, and to an untrained person, as far as a patient or client, this looks like acupuncture. And so it's really important that we distinctly identify acupuncture as a primary healthcare organization, in that this takes about 3 or 4 years. This is a license and a certification that we do not attain. It's based on Eastern medicine, which we also do not speak to. It uses terms like qi and meridians and tongue diagnoses and things like that. Again, not dry needling at all. As far as dry needling, the intention is to be supplemental and augmentative to the services that you're providing already. Rarely do I ever just dry needle any client, athlete, patient with the intention of it being the primary modality. 99.9% of times they're going to get corrective exercise afterwards or before, in that this is a jump start. It's a platform to take off from. As far as the theories around it, there's a couple of theories, and we'll cover them briefly because I know you want to see the magic up here in the show. So we'll get to that here in a second. But just theories about it: the motor end plate, the energy crisis, the radiculopathic model, the functional model, and the failed healing model. We'll go through these briefly, but it's important you understand because 99% of the questions I get from patients, clients, and other health professionals are related to, well, how is it different from dry needling? What is it supposed to do? And what do you use it for? So the energy crisis theory, this is based on calcium and sarcomere shortening. And it basically, in a nutshell, the increased demand that's based on the muscle, there's an increase in calcium, which makes the muscle relatively tonic and contractured at the time. Being so that the arterioles and the vascular supply of that muscle are coursing through the muscle itself. When the muscle contractures and holds in that state, it basically creates almost like a squeezing effect, and you get an ischemic effect from that. You can't clear the calcium because your arterial system is being compromised and venous system is being compromised. So you stay in this state of chronic contracture. The second is based on a motor end plate theory. And this is this term SEA activity is spontaneous electrical activity. It's based on the fact that there's excess acetylcholine, right, which is a neurotransmitter that exists in the motor end plate. It facilitates depolarization and contraction of that, well, of that muscle that is being innervated, all right? So the problem is in this spontaneous electrical activity, it continues to just prolong itself. There's not enough acetylcholine esterase, which deletes the acetylcholine. So again, you stay in a contractured state. The radiculopathic model is based on neural input and on Cannon's law, in being that a hypersensitized nerve, being a centrally oriented nerve, a nerve root, will affect all the nerve down its entire path. The reason I bring this up is because you will see a lot of therapists, dry needling certified therapists, that will needle the corresponding segment with the muscle itself. As in, if we were talking about some of the quad musculature, you may see some therapists do dry needling at L1, 2, 3, and also needle some of the hip flexors and or quad extensors. Does that make sense? And the reason being is that they intend to change the input from the spinal level and outward. The last two models, the functional model and the failed healing model, the reason I bring this up as well is because you'll see therapists also needle in areas that are not locally hot or painful, right? And the intention is to increase extensibility of the tissue based on kind of that interregional interdependence. And I'm sure you've probably heard this. This is a relatively hot topic with the SFMA and FMS movement testing and screening. And so it can be used to make changes elsewhere to influence more distal tissue, if you will. The failed healing model, the reason I bring this up as well is you can dry needle for non-trigger point related pathology. You are inserting a needle into areas. Inserting something foreign into an area is going to create a hyperemic response. You're going to get an increase in blood flow. So in some scar tissue instances, this is a great modality to help encourage blood flow and healing state of that, either scar tissue, some types of chronic tendinopathy, or maybe some just general failed healing response. Okay, so the proposed effects. Inserting a needle into this area, and this is a study that was published by Jay Shaw in 2012, and what he basically looked at was the changes in the chemical environment of the muscle itself. And again, I'm not going to bore you with some of this stuff because I know we want to get to some of the needling, but just appreciate that there is a massive amount of change that happens from this little bitty needle. All right, and we're talking about a needle, again, a solid filament needle that is a fraction of the size of a hypodermic needle that you're used to seeing with a shot or any kind of injection. I mean, you can fit one of these needles, and I'll show it to you, inside some of these injection needles. But there's a massive change, and everything from changing the way that spontaneous electrical activity is. It changes the amount of hydrogen ion that exists, and so it changes the acidity of, or the pH of that local area. It also changes the way your brain perceives that area. One of the kind of stories that I tell some of my patients when I'm speaking to this is, right now your tissue is sending a message to your brain. It's saying XXX, and your brain is interpreting Y. There's something there. It's almost like a computer that you're typing on a keyboard and it's showing up wrong on the screen. In some cases, this just kind of resets that, and you'll hear that term, that neuromuscular resetting. That's impossible to quantify. You can only just visualize and subjectively identify that. But we do know that it does gate pain like any manual therapy would. Let's see. So, some of the typical questions, and I'll kind of hedge some of these on the front end, but the how and the when. So, obviously this is the questions your patients and everybody asks. Does it hurt? It's not comfortable, but it's not a shot. Most people think of a needle, you think of the shot that you've gotten, it hurts, it bruises, etc. This is not anything like that. In most cases, you don't feel the needle actually penetrate your skin. What you do feel is a response of the needle, and it is not very comfortable in some cases, especially areas that are pathologic. Some of you are shaking your head. I could see that you've probably experienced that, and it's not comfortable. Again, there's varied responses. I have seen everything from crying to laughing to sheer panic to kind of that good pain that, oh, keep going, you could do this all day. I'm telling you, I stopped explaining it to patients because the spectrum is massive for the response that you'll receive. What we are looking for is this twitch response and this kind of twilight period of intervention. Most people leave very sore. You feel like you just got kicked. If it's in the lower extremity, you feel like you just ran a marathon. It's fatiguing almost. In doing so, in that 6 to 12 hours, you feel kind of crappy. I'll be honest with you. It's one of those deep tissue massages that you're really struggling with. After that session, though, after that 6 to 12 hours, you usually feel a lot better, and then there's an improvement in your general symptoms throughout, across the board. Everything from the way it feels, how good it responds, how you move, maybe you can run a bit further, etc. And then subsequent sessions usually are much less sore. This is a nice little excerpt I took from Jeremy Elliott, who works with the Redskins. He's the head AT there. He does a lot of this, and I'll let you read some of this. We're not going to spend time on it, but this is a first-hand account. They needle a lot. This is very popular in professional sports, not just football, in every sport. And I mean, as you can tell, I mean, of those, 75% have had good success rates, 50% experience extremely good success. Again, and you can moderate when you're going to do this. You wouldn't want to do it the day of a game. You're going to be sore after that. Just general experiences from myself. I use this from everything from posterior cuff pain to adductor groin strains, chronic tendon-related issues, really you name it. I use it a lot. It saves my fingers. It saves my manual skills because it's hard to get in there and do that stuff consistently. It also gives you a very specific, very direct treatment, right? I can't tell you how many patients I've seen with chronic hip pathology that come in, I've tried this, I get on a foam roller, I get on a lacrosse ball, I've had stretches, I can't seem to identify it. And we get in with the needle into the glute med in men, which are impossible to control. All right, it's impossible to massage that area. Okay, so what we're gonna do, I'm gonna bring Talal up here, who has graciously volunteered himself to get needles stuck into him. He runs up here, that's impressive, yeah. Oh, yeah. So if you wanna come up and see, I mean, it's gonna be relatively hard to see from your seats. We are gonna do the hip. So I'm actually gonna needle Talal's glute min and med, which he will tell you, because he knows what's coming, that this is not the most comfortable areas. So Talal, some of your glute will be exposed to the general public. I hope you're okay with that. So I'm going to do it reaching across so you can see this. Okay, so first I'm going to drape down. Okay, so quick anatomy, right? So I'm going to go ahead and find this greater troch here, top of the ilia here, so his PSIS. We're talking about, again, the most common areas that I like to needle are the glute min and the glute med. All right, so glute max is laying across over the top, right, more obliquely oriented. We have the glute med. If you come anterior, so is ASIS, that is nothing but glute med, right? It attaches all the way to the superior aspect of the posterior crest. Maybe 2 inches down, so just above where the greater troch is, you have glute med, but you also have glute minimus deep to that. All right. Again, it would be very hard for me to push and palpate through that, but with the needle, we get a very specific treatment approach. Okay, so what I'm gonna do is I'm gonna have Talal actually let you know what he feels, but I can go ahead and tell you what he's gonna feel. It's not gonna be the most comfortable thing. These are the needles, and again, if you wanna come by around lunch, I'll pass one of these around, or you can come take a look at it. It's very fine. All right, and so what we're gonna do is I'm gonna do a couple of needles for him, just because I like him. And again, to kind of go off of what I was speaking to earlier, it says acupuncture needles on the box. There are some newer needles that are coming out that are called Myotech that are dry needles, which for all intents and purposes is the same needle. But we're trying to get away from that as far as identifying ourselves with acupuncture. Okay, so alcohol over the area. So again, we're just going to kind of clean up that area a little bit. And this is very important, right? So anatomy, when it comes to dry needling, is really a lot of the certification. If you do happen to take a course, you're going to be amazed at how much anatomy you're going to take away from that. Because it's important, obviously, right? I mean, these are relatively lengthy needles that we're going to insert into somebody's skin. Okay, so Talal, you ready to roll, man? Yes, sir. Uh-huh. Okay, so we're going to go ahead and palpate again. All right, so again, I'm finding his ASIS, PSIS. We know glute med, obliquely oriented, greater troch. So right above that, right there is nothing but glute med. Okay, so what we're going to do is we're going to go ahead and put a needle in, all right? Go all the way down, and he'll tell you what he's feeling. That is his ilia right there. So that is the posterior aspect of the ilium right there. I'm hitting his, you see the faces around here. This is the best part. What do you feel there?
Like a burn, like a deep burn.
It's like a deep, achy burn. Okay. And again, I know exactly where I am anatomically. There's nothing else there. So I know I've got to glute med all of the fibers. Okay. So I'll leave that there for a second. I'll do one more, and then I'm going to shove some electricity through it so you can see it. I'm not kidding. So, oh boy, this is a show. All right, so again, we're going to come a little bit more distal. Okay, so we know the greater troch is there. I know exactly where the crest is, so deep to that. You can come a little bit deeper. That right there is glute med. I'm also hitting the ilium again. Okay, so we're going to leave Talal there for a second. I'm going to get my fancy electrical device, which is basically a microcurrent unit. It's just a stem unit with a pointer to it. So what we're going to do, we're going to see how Talal likes that. Yep. So you can see, right, there's no denying where I am anatomically. That is his glute min, and that is his glute med. And you'll sometimes, if I were to put 2 in his glute med, I could actually get him to rotate his foot a little bit, or glute min and have him internally rotate his foot a little bit. I mean, you can see that. There's no denying that, right? Okay. Most research will support the fact that around 10 minutes of needle in time is related to a hyperemic effect, and you get a very, very high hyperemic effect as far as increased blood flow and increased extensibility.
Chris, just so you're aware, we're down to 1 minute.
Okay, so that was quick. I know you wanted to see more, and there's more magic, but again, this is the intention is to identify and to kind of expose you to this, not necessarily to make you competent in going home and doing this stuff. If you have more questions, I'm certainly happy to answer some of those questions. So again, if you have anything, please grab me. But that is Talal's glute. Oh yeah. So I'll shorten up the All right. I think we're getting close to getting kicked off here. So, again, my name is Chris. I am with Memorial Hermann. I do a good bit of dry needling over the last couple of years. So we're going to talk about dry needling for the athlete as I kind of glove up here for a sec. As far as general disclosures, I am currently in the process of accepting a position with Kineticor, which is a licensure organization, dry needling certification organization. So that is a disclosure for me. There are multiple different organizations that do such, but that's just the one that I'm with. All right. So what is it specifically? So it's the use of a small filament needle inserted into the skin with the intention of helping abolish soft tissue related pain, improving extensibility, and helping change the chemical environment. All right. So again, these are small, very, very small needles, right? So most people think of needles as the hypodermic needles that are gauge needles. A dry needling needle can fit inside of one of those. They're very, very small, very fine, and they're full filament, right? So there is no injectable substance. As far as who can perform dry needling, PTAs at this current time, no. ATCs, there are some states that allow this. Again, I would encourage you to check that specifically. I couldn't find anything in Texas. I looked, did not see anything, but I know that that's in the process. Licensed massage therapists, not right now. They're working on that as well, but part of the Practice Act eliminates them from penetrating the dermis. So that changes that as well. Acupuncturists, obviously, yes, and then chiropractic care as well. So again, I always put this plug in. It is not acupuncture, and it's important that we distinctly identify that as not being acupuncture because it gets confused with acupuncture. It uses the needles, the same identifying needles as acupuncturists would use with a completely different approach, and it does not intend to identify the diagnosis of acupuncture, tongue diagnosis, chi, meridians, all of that stuff is not applied when we're talking about dry needling. All right, so a general thought about dry needling itself, this is always going to be used, it should be always used in conjunction with some other modality, exercise, soft tissue, stretching, whatever it may be. It should never be the primary modality used. That is what acupuncture is. That is the primary form of medicine. As far as theories, and these are theories associated with pathology. This is why we're doing the dry needling. Okay, a couple of theories that we'll go through and we'll hit them quick so we can get to the show and the fun. The energy crisis theory, this is related to calcium inside the muscle itself and the sarcoplasmic reticulum. But anyway, it's basically in its essence form is a shortened muscle that stays shortened, right? It squeezes the vascular supply of the local musculature and prevents it from achieving enough ATP to relax. Okay, so it stays contractured, and that's what they think a trigger point could be. Also, there's a motor end plate theory, which this SEA term is called spontaneous electrical activity, and that is too much acetylcholine in the area at the motor end point, so it facilitates a constant contraction. There's not enough acetylcholine esterase that is there to remove that. So you stay tight and contractured, and you create an acidic environment with a lower pH and an increase in hydrogen ions. Radiculopathic model, the reason I bring this up, and this just basically states that a nerve at its central location, the nerve root, will affect the nerves all the way down the chain. And again, the reason I bring this up is because you'll see a lot of therapists that will needle the corresponding spinal segment into the multifidi or in that local area, and also needle the muscle that it's associated with. So needling L2 or L3 or L4 when you're needling the quads also. Functional model, this is just basically identifying that you don't have to needle an area that is pathologic. If you're looking to make extensibility changes, you may needle somebody's hamstrings even though they're having knee problems, and it's that concept of regional interdependence. The last is called failed healing, and this basically identifies areas that are either failed healed or areas that are just generally low in the vascular chain of command, right? So scars, chronic tendon-related pain, you're punching holes in this with a needle, so there's going to be blood flow brought to the area. Proposed effects, and we're not going to spend a lot of time on this, but I just wanted to identify that there are a variety of effects that are associated with dry needling, everything from mechanical, where it improves the extensibility of the tissue, all the way to the electrophysiological, where it deletes some of this spontaneous electrical activity and allows relaxation. It also has some placebo, obviously, and also some neuromuscular effects, in which the way that I like this, this concept is that you have a keyboard, your body is the keyboard, and it's typing in a message, your brain is reading that message incorrectly. So if you can turn the machine on and off, it kind of resets that and it acts appropriately. The how and the when, logistically, does it hurt? This is the question that I get asked 100 out of 100 times at every conference. It does not hurt like you think it would, but it is not comfortable. And some of you probably experienced this. The needle is not the painful spot. You hardly even feel the needle. You feel the response to the needle, and it's very much like a cramp. There is a wide variety of experiences that patients report, everything from soreness to good pain to, oh my God, that's miserable, to crying, to laughing, to it's really variable. How long does it take? You're typically very sore afterwards, and that soreness can last anywhere from 6 to 12 hours. So in athletes, we're really trying to encourage them not to do this before an athletic event the first time. Once you have gotten used to that and experienced it once, you may be able to do that maybe early in the day with a competition at night. Most cases, that's not going to be the preference. Subsequent sessions are a little less sore, but again, I encourage them to go exercise, just not at a high level. This is an excerpt that I took from the Redskins athletic trainer who does a ton of this. And again, he speaks to his athletes about how often they're doing it, the success rate, and it's very high. They get a very good amount of response. And he speaks to what I talk about. Players don't get needled after Friday afternoon, leaving them primed for Sunday game conditions. All right. Let's move on a little bit. As far as anecdotally from my end, I think it's a fantastic modality, and I think it offers something that we rarely get a chance to do, in being that it's very specific, very local. It's very hard to massage in some cases all the time and take care of these athletes, and it's very hard to be so specific. And what the dry needling does is it gives me a chance to be extremely specific into an area, in sometimes areas that are not tolerated very well. Areas that athletes have tried to foam roll and things like that, and that they just don't feel like it's very responsive. So what we're going to do, I have Talal here. He graciously has volunteered, and we're going to do a little dog and pony show up here. So what we're going to do, we're going to actually needle Talal here. So if you want to come on up and see, that's totally fine as well. We're gonna needle Talal's quads, which he'll tell you is not going to be the most enjoyable experience. So what we're going to talk about, and again, anatomy is a massive part of the certification, because again, we're talking about penetrating the skin, and it's very important to know the anatomical vascular structures, the neural structures as well. So what we're going to needle is rectus femoris, right? Pretty far distally, well, I say distally, probably in the middle aspect of the thigh. We know his vascular bundle, neurovascular bundle is up here, the femoral, right, is all of that is up here, and it courses more medial, and if you find his adductor, the hiatus is down here. So really, right here, you've got nothing but rectus. Underneath that is the vastus med, and then the femur. And we'll actually hit his femur. He knows this is coming, so I can say this. I usually don't say that to the patients because, let's be honest, that's not exactly. So, so again, the experience is very variable, and the little excerpt that I give to some of the patients is I usually tell them, this is not going to feel like a shot, but it's not going to feel very comfortable. And what I'm going to do is I'm going to put a few needles into Talal, and then we're going to shove some electricity through him so you can see his muscle contract. The electrical current is often used as a supplement to the technique, and it works extremely well. So again, if you can look, I don't know if you can see that. It is, we're talking something extremely small, right? This is not a gauge needle. You can almost hardly tell, right? So what we're going to do, we're going to shove this into Talal's leg here for a second, right? So palpation skills, obviously, sterile needle techniques and all that stuff too, but we're going to go right in through the middle of his thigh, right in through his rectus. And you can, Right? You can feel that. And I'm hitting his femur at that point, right? Okay. And again, it doesn't feel like you would think. Okay. So we'll leave one there.
It's like a burn.
Yeah. So you actually don't feel a different response from the bone. So you can see a little twitch response out of that. That's a good sign. I mean, that's the area where we want to be. So this is a little further up. He's got a little bit more girth to it. So we actually didn't hit the bone that time, but you don't have to. There's a lot of different methods and methodologies to needling itself. So this is a microcurrent unit that just can send a small amount of electrical charge through the needles itself. So what we'll do, and I'll kind of show you what this is going to look like. Okay, so we'll kind of play with the intensity a little bit, and you can see a little bit. Okay, that is his rectus, right? Some of his VM as well. So anatomically, it's very beneficial. I know exactly where I am. I know exactly what tissue I'm in. And again, it'd be very hard to get deep enough to really massage the vastus medialis. Not that it's necessarily pathologic, but I mean, most people don't tolerate that. I mean, how many of you have foam rolled on your quads? It's not the most enjoyable thing in the whole world. So if you can get a response with a couple of needles, however it's intense in the minutes that it's there, but it's much less than rolling around that foam roller for 20 minutes, right? So again, that is dry needling. We'll go ahead and get these out of Talal because I'm sure he's ready to have. It would be around 10 minutes. It depends. It totally depends. Treatment could last anywhere from a couple of minutes if the patient's ready, like, hey, get them out of me, or upwards of 10 minutes. There is research that has showed that the needles are left in for around 10 minutes, that there is a really high hyperemic response. So you get increase in blood flow, increase in extensibility. Most patients, I'll come in, drop some needles, do a little bit of stim to kind of make sure I know where I am in the right place in the tissue that I want, especially in the lower leg, as well as provide a little bit of a supplement, and then I'll let them sit there. I'll come back in 5 to 8 minutes and then go ahead and pull them out. And then we'll either, if it's the first session, get on the bike, kind of loosen up, or if it's subsequent sessions, go hammer some quad sets or some long arcs or whatever we're intending to do, or some quad stretches if we're looking at maybe some patellofemoral issues, etc. Again, completely variable. She asked how many needles you need to put in, and that's completely variable. It depends on the treatment you're trying to achieve. More is not necessarily better. Some patients don't tolerate that very well, right? I mean, this is a little bit of an anxious environment. And so I'll put a lot of patients prone, to be honest with you, because they don't want to see the needle. Totally fine. I get that. You don't have to see it to feel it. I promise you that. But it totally depends on the treatment you're trying to induce. In areas that are really hypoemic, when you're talking about blood flow and avascular tendons, things like that, I'll put multiple needles because I want as much blood flow into that area as possible. And so the next question is, right, do you ice after? Superficial ice is not going to affect me hitting the deep layers of the vastus medialis. It doesn't matter. He can put ice on it all he wants, and it'll help with maybe some bruising over the area, maybe with a small little hematoma if you hit a blood vessel or maybe if you hit a nerve or something like that, there may be some hematoma. But, we're talking about very small. And people always say, well, that's pretty dangerous. I'm like, yeah, but people get shots all the time. Right? And that needle is way bigger than the needle I just put in his leg. You may get a little bleeding, but again, how many of us have bruised from a flu shot? This is way, way less than that. So, any questions? Yeah. We do worry about infection. There is a couple of guidelines that we support as far as post-operatively. I won't needle anybody anywhere on their body 6 weeks, up to 6 weeks after their surgical procedure. I won't needle the local area. Let's say if it was a total knee, for instance, not even anywhere around their knee for up to 12 weeks, sometimes longer than that. Obviously, because there is a risk. The risk is extremely low, but if I put a needle in somebody and they happen to get an infection, it's an easy tag to pin on me and the needling for such. So and that's Connecticut's policy as well. We don't even instruct that. We encourage everybody not to do so. But yes, there is. Any other questions at all?
What about somebody on blood thinners?
Another good question. That is a precaution, and that is up to the needler's discretion. It just depends. You know, he asked if people on blood thinners. Again, I think that's a good question. I have done that before, and everything was explained up front to the patient. You know, here's what we're going to do. I called the physician. I talked to him. What do you think? He said, you know, I think the needles are small enough, and that I would be very surprised. I mean, if you draw blood, that's way bigger than the needle. So, again, it's about everybody being in contact and in the know before you just drop some needles in somebody, you know.
What about back, neck?
Absolutely, absolutely. So we, again, the radiculopathic model, I will needle for any type of pathology and even into the multifidi of the lamina. So we're talking down into the lamina of the spine. You can get some incredible responses with low back pain, with inhibiting back pain, or activating somebody's maybe lower lumbar multifidi with a little bit of stim in that area. So yes, absolutely. Neck as well. Now, there's a couple of levels to the courses, and so it depends what level you've taken. Some areas are a little bit more off limits because the next question is the lung field, right? That always comes up. And yeah, you have to take care to identify areas that are a little bit more dangerous. I'll tell you this right now, the most dangerous areas, and I do a lot of tension headache needling, and that is into the, you know, basically into the nuchal line, into the inferior and the superior nuchal line. You can get some incredible responses from that as well. You know, upper trap and that insertion back there, a lot of that, it kind of grabs that greater occipital nerve. You can get some of that ram's horn type presentation. The most dangerous areas are there, as at the base of the skull, right, and in the lung field. And so, obviously, if you were to see this done or get this done to you, it should be done by somebody that can effectively explain what they're doing, why they're doing it, label areas. I mean, they should give you an anatomy lesson before they stick a needle in you, right? Make them draw. I mean, I brought a pen up here. I was going to draw all over him if we had time. So that is imperative that the person that you are working with can just spit it out. Because again, right, it's invasive. It's an invasive procedure. So when I started, I was working with somebody that was performing it, and so I kind of mentored with them a little bit. Then I went and took a course, the level 1 course, which eliminates basically the torso and then the upper neck, so you don't even get to do those areas. So they certify you in those areas. You go out for at least a year to a year and a half. You actually, through Kineticore in most states, they won't even let you take the course until you've practiced for a year and a half or two, depending on the state. You have to go practice for a year and then document needling exposure to 200 patients before you can even take level 2, which gets into a little bit more of the, you know, dangerous areas. And so again, I've been needling for almost 4 years, a little over 4 years, and again, as part of faculty, obviously, to teach this stuff. I mean, because we have acupuncturists, we have chiropractic, we have physiatry that come to these courses, and so we had an anatomy professor that came to the course, and so she loved to point out all kinds of things that we weren't identifying, you know. So, but no, so we see a variety of scopes of practice, and so it's, again, I encourage you to vet anybody that's going to do this stuff so that it helps everybody. It helps the organization, it helps the certification, and it really helps the safety of you, your athlete, the parents, whoever. It doesn't matter.
So as far as physical therapists, you can be certified in certain levels, or once you're certified in. So
that's a two-part. No, absolutely. So different organizations identify different things. We got enough time? Okay. So different organizations have different levels, if you will. Kineticore has been around for a while, and so their kind of leveling is very strict. And so, like I was saying, some of the areas you cannot do unless you've taken level 2. Could you do them? Sure. But Kineticore is not going to be held responsible for, or anybody will be held responsible for you kind of acting outside of your scope.
So as far as the state, as far as being certified, licensed by the state to do this, what level do you have to reach for licensure?
So it's not actually a license. No, it's not a licensure. Now the FSBPT, so the federal board they've created a task force that is producing and identifying minimal base criteria for all dry needling, competencies, things like that. Because right now it's still relatively new and there's not enough competency-driven standards out there. And so that's soon to come. And I think that's a step in the right direction, so that we're making sure that people are continuing to remain competent outside of just being certified once.
Right now, somebody said they were dry needling, you're saying we need to ask them.
I would. I mean, you don't have to, but
Are you?
well, yeah, just ask them what level of training, and they should be able to articulate that.
Right now in the state, there's not any, like somebody.
No. Thank y'all. Yeah, absolutely.
Sorry, I didn't know.
No. Yeah.
Hey, one of the longest injuries.
Okay. Can we go ahead? Oh, okay. Okay. So I think we're going to go ahead and get started. I'm sure we'll have a few more trickling through, and that's okay. I know everybody wants to get to the big show. Talal's our volunteer, so he's getting pretty sore. So we gotta roll along and try to get needles stuck into him at this point. So dry needling for the athlete. We'll talk about a variety of different things, everything from kind of what it's used for, what I use it for, what are some of the mechanisms. A couple of disclosures. I am in the process of becoming faculty for Kineticor, which is one of the one of the certification organizations in dry needling. So yeah. So what is it exactly? It is a manual technique that uses a small filament needle that's inserted into the skin with the intention of abolishing soft tissue pain, improving extensibility of the tissue, changing the chemical environment itself, and a variety of other things we'll discuss. But the big thing is that it's a solid filament needle, right? And we're talking, the reason is that people tend to think of it as a shot, right? A hypodermic needle that is a gauge needle. This is not a gauge needle at all. It's an acupuncture needle itself. So you can fit some of these needles, and I'll show you whenever we get to it later. I mean, you can actually fit some of these needles in a gauge needle. I mean, they're very fine, rounded tip needles. As far as professions that can perform it, obviously PTs are able to do so, and most courses are designed towards physical therapists. PTAs not at this current time based on the level of education. ATCs, there are some states that are allowing this to happen. Most of these they're associated with a PT in the area, so the AT practices with a PT. I don't know the exact state practice acts throughout the country. I looked up Texas, and it's a little vague as well, so I'm not sure exactly there as well. Licensed massage therapists, most are no, because they're not allowed to penetrate the dermis of the skin. They're lobbying for this, and so that may change, but it's not at this time. Acupuncturists, obviously, yes. Chiropractic care, yes, and then physiatry, yes as well. Okay, so the reason I put this in here is because this is always a question. Every patient comes up, oh, you do acupuncture. No, I don't do acupuncture. It's really, really, really important that we identify this as dry needling and not acupuncture, because there's a turf war going on with acupuncturists, and rightfully so. However, we don't use any of the same diagnosis. We're not the same intervention tactic. Acupuncture is a primary form of medicine. Right, they go to school for years, they learn acupuncture, it's on oriental medicine, it's tongue diagnosis and meridians, etc. We don't use any of that. We use palpation skills, all right? And so it's very, very different from that. As far as the thought about dry needling, it is also important to realize that in dry needling, this is a supplemental, a secondary technique. You should not go to somebody and then dry needle you and then kick you out. There should always be some corrective exercise, stretching, some form of additional corrective exercise associated with that. So as far as theories, the reason we're going to talk about it is because this directly relates to what the needle does inside your body. And that's usually one of the questions as well. So there's a couple of models. We'll touch them quickly. But the first is the energy crisis model that's related to calcium and shortening, sarcomere shortening. Basically, there's an increase in calcium in a trigger point located region. That increase in calcium creates a hypertonic state. And that hypertonic state squeezes the muscle, and it squeezes all the vascular structures in the area. So it makes it impossible for it to relax. It's kind of a feed-forward mechanism. So you stay in this contractured state. The second is the motor implate theory, and they kind of work together. But this term SEA, which is spontaneous electrical activity, it's based on an excess of acetylcholine at the motor endpoint, right? Which is a neurotransmitter that facilitates contraction of the, or depolarization and contraction of the muscle. There is an absence of acetylcholine esterase in some of these hyperactive and hypernociceptive trigger points, which again facilitates continued contraction, which is why that's that palpable knot in a trigger point. As far as other related issues, the reason I bring this up is you will sometimes see dry needling therapists needle the corresponding segment to the muscle they're needling as well. And this is based on Dr. Gunn's model on the Cannon's Law, which states that a centrally affected nerve, the nerve root, can affect the nerve all the way down its chain and all the muscles it innervates. So you'll see maybe a therapist dry needle somebody's multifidi of their L2, L3, L4 region, and also needle somebody's quads as well, right? And that's the reason why you're kind of hitting it proximal and distal. Two other models, functional model. This identifies the fact that you'll see some therapists needle areas that are not pathologic for the same reason that we would treat maybe somebody's hamstring extensibility and patellofemoral pain, etc. Failed healing, it doesn't have to be a trigger point. You can also needle areas that are somewhat avascular or have failed healing, like tendinopathy, areas of scarring, with the intention of helping relinquish some of that. And I won't get into all of that stuff. But some of the proposed effects, and again, we won't spend a ton of time on this, but the big things that I want you to realize is the mechanical effects. It's going to change the way the muscle feels. It usually feels a little bit more pliable after dry needling, and we feel that that's related to the changes in the chemical markers and the holding state of the muscle. It also changes the SEA, or that spontaneous electrical activity, by kind of resetting the motor end plate. All right, so you kind of change that motor end point. It allows it to relax. And the other thing is this neuromuscular kind of resetting action. And I'll tell a lot of my patients this as well, that imagine your muscle is a keyboard and it's typing in something for your brain to read, and your brain is reading something inappropriate. And so if you just kind of shut down the system for a brief second and let it restart, it should restart appropriately. Other effects, chemical effects, we talked about a little bit, and then the neurophysiological. And there's also a lot of placebo as well. So the how and the when, obviously these are important questions to ask, is, you know, when should I do it? What's it going to feel like? Most patients are terrified because it's like, oh, I don't want a shot. This is going to hurt. It's not comfortable, certainly, but it's not a shot. You're not going to feel the needle penetrate your skin. You're going to feel your body respond to the needle. It's very, very, very varied across patient care. I've had everything from laughing to crying to anxiety to fear to good feelings, like how many of these can you stick in me? Like, I'll stay here all day if you'll let me, kind of thing. So it's very varied. The big thing is you're going to feel sore after this, and your athletes are going to feel sore. I mean, this is like I tell, in the lower leg, you're going to feel like you just ran a marathon. I mean, it's that tender and that sore. And that can last 6 to 12 hours. After that, you kind of hit this twilight period where it feels incredibly, incredibly better. Everything from pain to extensibility and so on. It really does. After the first session, I'll have them do some type of general exercise, a bike, upper body bike, something to that effect, nothing strenuous. Subsequent sessions, you can really get after it. I mean, I'll have a lot of patients that are second, maybe third needling session. They'll go do exercise. They'll go maybe do some of their corrective cuff work, or some of their mobility work, or you may choose to do some spinal mobilization as well. All of that is completely appropriate. This is a little excerpt I took from the Redskins ATC, just speaking about how often they use it. And one of the things it says, as a result, most players do not get needled after Friday afternoon, and that's to prepare them for Sunday. It's just to mitigate any of that lingering soreness that they may experience. But most guys, after they get it once, they know what their body's going to do. Very rarely is it you've been needled 3 or 4 times and you know exactly what it is, and then that 5th time, it's an absolute train wreck. Usually it's very consistent. So as far as anecdotally, how often do I use it? I use it very, very, very often, almost daily, if not more than that. Again, it saves my fingers. I'll be honest with you. As far as manual therapy, you can get very specific into these areas. Some areas that you cannot palpate anyway. Deep musculature of the hip, right? Very hard to get in there and release some of that. As far as the calf itself, I mean, it's very hard to mobilize somebody's posterior tibialis or flexor hallucis. I mean, it's just not, you can't get your fingers in there. Even if you could, it would be miserably painful for the patient, and they probably wouldn't tolerate a whole lot of it anyway. Tension headaches, absolutely, into the nuchal line. There is, really, the effects are really broad-based. And as long as this person knows their anatomy well enough, you can really, really see some great changes with this. And so as far as conclusion, and we'll get into Talal here for a second, but anecdotally, this stuff really works, and I would really encourage you, if you have access to this, at least experience it. If you're going to have your athletes do it as well, have somebody do it to you so you can appreciate what this is going to feel like, and then use it if that's appropriate for you or your athletes as well. You'll really see some fantastic changes. So we'll get to the show. Talal has volunteered himself and has been stuck twice at this point, so he's still walking. That's a good sign. So what we're going to do, we're going to bring Talal up, and we are going to needle, what do you want to do, your shoulder, you said? So we're going to do Talal's posterior cuff. And please, come on up. Y'all can absolutely come on up, and we'll go through this. Yeah. So I really like this for posterior cuff, internal impingement symptoms, or some type of cuff tearing. No, go prone and put your arm off the side of the table for me. So one of the things I brought up in the last group is if you do, I would really encourage you to identify therapists that have a lot of experience in dry needling, for the simple fact that there are areas in the body that are a bit more dangerous than other areas, right? Obviously in the lower leg, neurovascular bundles are what you want to watch out for. But again, people get shots all the time. People get flu shots all the time and they bruise. These needles are way smaller than that, so the chance of that happening is smaller, but it can. The lung field, right? That's a very big concern that we should all appreciate. You should have no problem with that in somebody that knows and has experienced and done this quite frequently. All right, so what we're going to do is we're going to do Talal's posterior cuff. All right, and so what I'm going to have him do is just pull back into me. See, yeah. So I'll identify his lat. Right down here. You can relax. Right. I can feel his border, but I just kind of wanted to show you that. So I'll identify his lat. All right, internal rotate for me. See, yeah, just from that. So Terry's major, right above that. Relax. External rotate. All right, so you can see, right? You can identify pretty readily. Relax for me. Even if you couldn't identify that, it's still very easy to palpate medial border, inferior border. I'm sorry, yeah, medial border, a lateral border over here, and then you can see the spine. Okay, so what we're going to do is we're going to go into his infraspinatus, and we're going to see what we can find, and then we'll shove some electricity through him so we can really find it.
Ride the lightning.
Ride the lightning. There you go. All right, so sterile needle techniques obviously are extremely important, and the reason I bring it up, and it was a good question last session as well, do you do this in postoperative patients? It is the policy of Kineticor, I can't speak to other organizations, that we don't needle anybody that is post-surgical for around 6 weeks unless you've spoken with the physician. We don't needle the local area. Say if it was a cuff repair, I wouldn't do that for up to 12 weeks in the cuff itself. We may needle elsewhere, but not in the cuff itself. The reason is there is an extremely low risk of infection. However, if I were to do this and they would get infected for reasons that aren't my fault, it would be very easy to pin that on the invasive procedure of needling. So it's something that we just kind of monitor and do as such, something to keep in mind. Okay, so what we're going to do, we're going to needle posterior cuff here in the infraspinatus. And so what I want to show you, right, this is the needle itself. All right, I mean, this is, right, I mean, if we're looking at it, this is tiny, right, compared to a gauge needle, which is much bigger. All right, so what we're going to do, I kind of cleaned him off a bit. So again, same rules apply, and usually I'll actually draw on patients. I'll draw them the borders of the scapula, kind of give myself some landmarks. I know what is here, right? So his scap is kind of protracted a little bit, so it's important to appreciate the anatomy that he's protracted a bit. So I'm going straight down this way. I'm going to hit I'm basically going to hit his bone, and you're thinking, oh my God, that sounds terribly painful. It actually is not. The bone you really don't feel very much. Okay, so border, we're going to go right through there. Okay. There we go. And there, right there, is the posterior aspect of his scapula. You feel that, T?
Yeah, not too bad.
Yeah. So it didn't really twitch, and that's okay. You don't have to get a twitch response to signify that if this is going to be effective or not. So we'll do one more so we can give us a couple of anchor points. Again, most are pretty tender right through here as well. Yeah. Yep. Okay. So what we'll do, we'll shove some electricity through him. This is a microcurrent unit, basically tens for intensive purposes anyway. You can turn the intensity up, and we're going to actually turn the hertz up high enough where we can get a little bit of a facilitated contraction. It's not going to be a tonic contraction. You'll see the pulse. Basically, his muscle will twitch at the frequency of the beep there. That's how often it's sending signal through. So let's see what we can do here. Yeah, so a little bit of contraction. There we go. So I'm feeling it. There we go. If you can see his arm kind of twitching a little bit, I mean, that is external rotation. I'm inducing external rotation right now. And you can see you can trace it all the way up, right? So if we do it a little bit slower, there we go. You can kind of see that tick. And then, much less comfortable, you can create tetany, right? So that is full-fledged tetany of external rotation, basically biased infraspinatus. Okay, so the next questions I usually get asked, so how long do you do it for? Is that a whole treatment? Do you leave them in there? Do you take them out, et cetera? It depends on the region. In this region, I would be okay with it because I know exactly where the position of the needle is. In the upper traps, things like that, I probably wouldn't leave that in because of the lung field itself. There's research that has looked at duration of treatment. If the needle is left in for around 10 minutes, there has been shown to be a hyperemic effect, and so you get a change in the local blood flow response of the area. You get a little heat in the area. You may want to do some stretching, et cetera, after that. You can leave them in and leave patients there as long as you feel confident that they're not going to move, especially in areas. If it's in the lower leg, I mean, there's actually courses that teach that it's functional dry needling. Well, you'll needle somebody's gastrocsoleus complex in a squat. So with help in changing the way that is. 5 minutes. So we got about 5 minutes left. We have plenty of time. If you have any questions or anything at all, please ask. Typically what I'll do is I'll have, so Talal has had this before, so what I'd have him do, maybe if he's having some internal impingement symptoms or maybe a small cuff tear that's suspected, we'll do this, leave him in for about 10 minutes, come back, all right, man, go hop on the arm bike for a second, just kind of get things loosened up, get right into your either, chest stretches and get right into your cuff exercises. Any questions about that? And that's it. Magic, Talal. Still attached. So any questions about treatment, about effectiveness, about, I can tell you stories all day. Obviously, I've been doing this for around 3.5 years, almost 4 years at this point. So I've done just about everything from tension headaches to neural tension to scar tissue, you name it. We do not needle joints themselves, so I would never intentionally penetrate a joint. And so we kind of take measures to do such. So as in, like, if the VMO, I could do it seated and just kind of pinch and come more obliquely oriented to, avoid kind of hitting the end of the capsule itself. But yeah, any questions? No, nothing. Yeah.
Use it for more chronic, like tendinosis type injuries.
Absolutely. So she asked if we use it for chronic tendon pain. Absolutely. So tendinopathy is actually an area that I really like it for the simple fact that, right, you're just punching holes in an area that's not very vascularized. And so in doing so, you create blood flow and maybe begin that healing process again in an environment that failed the first time. And it gives you the opportunity to kind of control that. Most patients with chronic tendon pain, right, there was some insult at some point and they blew it off like, I'll get better. I just rest it for a little bit. They rest and they end up creating a failed, it's really an incompetent tendon. This way you can kind of turn everything back to day one, start that healing process, and now you're in charge. You can have them come back and you can start maybe an eccentric loading program, or what I kind of use is an isometric loading program, and then progress it into an isotonic heavy-based tendon program. But it gives me the opportunity to kind of dial back a bit and get back to square one, because in many cases, these chronic tendon issues don't, it's very hard to get the tendon response because it's so degraded at that point. We don't get them very early, right? Anything else at all? A couple other things, and we talked about this earlier, posterior hip pain, FAI, right? This is a big popular topic right now. With FAI, I see great benefits in using it with glute medius and glute minimus, right? We don't talk about those muscles very, very much because they're hard to palpate, right? You got to really get in there to get somebody's glute med. Even harder to get glute min, right? Because it sits underneath glute med. And so to effectively palpate or effectively mobilize that tissue, it's almost impossible. A, because you're going to kill your fingers. B, the patient's got to sit there and tolerate you just burying your hand in there. Even if you use a tool or a lacrosse ball or whatever you want, it's not comfortable. I'm not saying that this is more comfortable, but it's specific. I can drop a needle all the way down to the ilia, the posterior aspect of the ilium, and basically hit nothing but glute minimus. I know exactly where I am, and I know that I am penetrating the glute minimus. And I've gotten some really nice responses from that. Everything from, from hip OA to FAI to things of that nature. So yeah, I think there's a lot of different areas that this can be used. And we talked about this last group. Make sure that if you're getting this done or you want your athletes to do that, kind of vet somebody that's done this. There's a lot of certification organizations out there. And what I challenge the last group is make that person give you an anatomy lesson, right? You should feel confident. Like, I know exactly where this is. I know where I'm putting the needle. I know what I should feel. You may experience this, you may experience that. Make them tell you this stuff so you feel comfortable that they know and they've done a lot of this stuff. So, any other questions about anything? Awesome. Well, thanks for coming. And like I said, if you have anything personally or anything, please stop me and ask. Thanks. Thanks, Steve. see here. I think we'll go ahead and get started. Kind of stay on time here for a second. So, my name is Chris. Work for Memorial Hermann, work in the Ironman clinics. I've been needling for almost 4 years now. So we'll talk about dry needling in the athlete. Just one disclosure for me. I am recently being onboarded as a faculty member with Kineticor, which is a certification organization specifically for dry needling. So get that out of the way. As far as what is dry needling, all right, so this uses a small full filament needle for the abolishment of soft tissue pain, the changes in chemical environments, and the extensibility of soft tissue. Who can do it? There's a couple of, it's an evolving landscape, we'll say that. PTAs at this current time, no. ATCs, this depends on the state. Some areas are allowing ATCs to do such. The problem becomes finding a course of study. Some organizations are not allowing ATCs to take the course themselves. So I would investigate that if that is something you're interested in. Licensed massage therapists, no, not at this time, because their practice act states that they can't penetrate the dermis with any of their interventions. Chiropractic and acupuncturists, obviously yes. Physiatry, yes as well. So what it is not, and the reason that I bring this up is very important because there's a waging turf battle right now with acupuncturists and dry needling. The reason is that dry needling does use acupuncture needles. This is changing a little bit, but as of right now, the needles that I have, they're acupuncture needles. We do not perform acupuncture, and it's very important because a patient will see that and they'll say, or a client for that matter will say, oh, you do acupuncture, great. No, it's not acupuncture. We don't operate on the same principles as acupuncture. Meridians and tongue diagnoses and qi. All of that stuff is very specific to acupuncture as a primary form of medicine. Dry needling is a supplemental form of manual therapy. Most always, and this should be the case, you should be using this in conjunction with corrective exercise. Stretching or some type of cuff exercises or lumbar stabilization exercises. It should always be used in conjunction. It is not an isolated treatment principle. As far as pathology theories, the reason I bring this up is one of the questions I get is related to what does the needle do and what's happening. And so it's important you understand the theories behind the pathology before you go into explaining what is changing. So a couple of theories. The first is the energy crisis theory, and this is based on the trigger point or the tender point phenomenon in that you can palpate that kind of firm mass of a trigger point. And it's based on, this theory is based on calcium. An increase in calcium leads to a contraction of the muscle. The contraction of the muscle itself squeezes all of the vascularity inside the muscle. So what you get is an area that just can't relax. It's not getting enough blood flow to the area to relax. The second, which kind of goes hand in hand to a small degree, is the motor end plate theory. And it's that this dysfunctional motor end plate is producing SEA, which is spontaneous electrical activity. It's just constantly turning things on because there's too much acetylcholine and not enough acetylcholine esterase, which is needed to clear the acetylcholine out of that junction. Right, those neurotransmitters do not. It's too lopsided, and what happens is that forces the depolarization, further calcium release. So they kind of go hand in hand, and that's what that trigger point is said to experience. The radiculopathic model. The reason I bring this up is because you will sometimes see dry needling therapists that will needle the multifidi or the local segment associated with the muscle you're trying to change. So imagine needling L2, 3, 4 multifidi. And also needling the quadriceps group. So you needle proximal and distal. It's based on this Cannon's law that hypersensitivity of the nerve root manifests itself through activity throughout the entire nerve root chain, the nerve chain itself, distal all the way down. The last couple of models, functional model, this explains why you may see therapists needle areas that are not directly related to the area of pain, as in needling somebody's hamstrings for patellofemoral pain or anterior shoulder pain as impingement and needling somebody's rotator cuff. The last is failed healing. You don't have to needle trigger points. That's a little bit of a myth. You can also needle areas to change the chemical environment and bring blood flow to the area, as in chronic tendinopathy, or in some cases, scar tissue. Proposed effects. We're not going to spend a ton of time on this, but I do want to point out a few things. Some of the proposed effects are related to mechanical and electrophysiological changes. There has been studies that have shown that there is lessened SEA, or spontaneous electrical activity, after insertion of that needle into that area. So it changes the complexity of that motor endpoint. It also changes the way the muscle feels. It'll change the extensibility of the tissue, so you can either stretch further or able to tolerate more stretching itself. There's also this neuromuscular resetting phenomenon, and the way that I explain this to patients is, imagine your quad is delivering a message. It's typing in a keyboard, it's typing XXX, your brain is reading Y. And so there's a disconnect there. And the whole principle behind it is you're just kind of resetting that environment, turning the computer on, off, and turning it back on, and letting it reset itself. A couple of other effects, and we won't get into it, but chemical effects, it changes some of the biochemical markers in the area. It raises the pH. Typically, trigger points are acidic, high in hydrogen ions, and so it can change that. It can help release some of those hydrogen ions and allow them to be absorbed. The how and when, probably some very important questions. So does it hurt? This is obviously the most common question that I get asked. It doesn't hurt like you think it would. This is not a shot, right? So most people see a needle, oh, this is gonna feel like that flu shot that gave me a bruise and I felt terrible for 2 days. It's not that at all. You really don't feel the needle. It's a rounded head needle. This is not that hypodermic gauge needle. However, you do feel the response of the needle in the tissue, which can be extremely varied throughout patient care or client care for that matter. I've had crying, laughing, pure anxiety. I've had, autonomic responses where their heart rate kind of flushes a bit, their skin kind of flushes a bit, they feel uneasy, nauseous. And you have the people that are like, oh, this feels amazing. How many needles can you stick in me? I'll stay here all day. So you really get a variety of responses, and so it's impossible to really define that. How long does it take? So the treatment sessions usually last anywhere from 5 to 10 minutes. And how are you going to feel after? You're usually pretty sore. So we're going to needle Talal's calf here in a bit. It is going to feel like Talal just ran a marathon. I mean, that's how sore you're going to feel. It's almost obtuse how sore you're going to feel, to be honest. And it depends on the area also. The first session is usually the worst. You're going to feel very sore for 4 to 12 hours, in which case that twilight period sets in and you feel a lot better afterwards. Changes in extensibility and pain, etc. Subsequent sessions, though, are usually much less sore, and you can start to incorporate corrective exercise immediately afterwards. So you can have somebody needled and then go out and perform their entire session afterwards. So as far as anecdotally, when do I see and when do I use it over in my practice? I use it, I'd say, on a daily basis, to be honest with you. I get a lot of specific referrals for certain types of conditions. And I hate that it's become a little bit of a last-ditch effort modality. I get a lot of dateless and doubtful patients that are like, well, I failed everything else. You're supposed to be the guy that can fix me. You better be that guy, kind of thing. And it's a little unfair. So the outcomes are varied because of that. But I've seen it work in a variety, everything from neural tension changes to FAI, right? The popular term of femoral acetabular impingement. Talal is going to speak to that later, but I've seen a variety of changes in that, from hip pain, from OA, from things of that nature. So it's very, very useful. It's important that you find somebody that meets your goals as far as athlete care as well. So as far as general conclusion, I think for me, anecdotally, there's a fantastic outcome associated with dry needling. I would say 95% of the patients that I see get a positive outcome. The other 5% are neutral. It's like, I didn't feel much different. Maybe I didn't do the right area. Maybe I wasn't in the right spot. But most people, I've only had a very small percentage of people that said, you know what, I feel worse. but it's usually not related to the needling itself. Bruising, a little bit of blood in the area, that's all normal as well. So what we're going to do, we're going to bring Talal, who has graciously volunteered himself to get needles, get needled all day long today. We're going to needle Talal's gastroc and soleus. And so please, if you want to come on up and watch, it's up to you. Up to you. Which side do you want? Let's do right side. All right, so what we're going to do, we're going to go ahead and needle his gastroc soleus. So anatomically, as far as this region is concerned, there's really not much to worry about because everything is pretty much shielded from his gastroc soleus, right? So the tibial nerve is something we should appreciate, but it is anterior to the soleus and posterior to the posterior tibialis. So we're talking about like it's way down in there. And so the way that we approach that is we kind of use it as an angled obliquely oriented approach. So there's no way I should really hit anything. Now, of course, Talal is going to be complicated and his nerve is going to be shifted over. So Chris hits the nerve. Oh God, Talal's going to die. No, it's not anything like that. Patients will report that like, oh, like sparkles. That felt like it shot down my foot. That didn't feel very good. Okay, fine. You just draw the needle out and you go to a different area. You're not going to hurt anything. Same thing with arterial arteries and veins. If you hit something, it may hematoma a little bit. You may bruise. It may bleed a little bit. And that's fine too, right? We get flu shots all the time by this big gauge needle. People bruise all the time from that stuff. And so again, I can sit here and tell you and give you an anatomy lesson, and your therapist, whoever if you do decide to get it done on yourself or for your athletes, they should be able to tell you all this stuff. Here's what we're protecting. Here's some of the areas that we stay away from. Here's this, this, and this. Give you an anatomy lesson for this stuff. But I'm going to give you this big fancy anatomy lesson, and he's going to be abnormal, and I'm going to hit something anyway. So expectation is important so that the patient is not like, oh, you didn't tell me it was going to be like that, and now I'm not comfortable. So what we'll do is gastroc soleus, right? So we'll hit both heads, medial and lateral. We know the tibial nerve is directly, basically anterior behind the tibia and behind his, basically just posterior to the posterior tib, right? The common peroneal has already split. It usually splits above the popliteal fossa. It's around over here, right around his fibular head, so I'm really not worried about that either. Most vascular is so deep at this point, I still shouldn't hit that as well. So we're going to go here, here, and then for the soleus, what I like to do is find kind of that fold, that gastroc fold, come a little bit distal to that, and we can do the same approach. You can kind of just move it off to the side and come like this. There's no way I should hit anything in that department. Okay, so as far as sterile needle approach, obviously that is a major concern, and so we'll commonly go ahead and wipe down the patient itself. All right, and as far as needles, so I want to show you so you can appreciate what this is. That is the needle, and I don't even know if you can see that from where you're standing right now. I mean, that is, so this is how fine we're talking. Minimal. This is not this big injectable gauge needle, right? So what we're going to do, go ahead and put some needles into Talal here. So we're going to pinch the skin a little bit, come out to the side. And you can see a little twitch. All right, so that's that local twitch response. That is hitting areas that are, for whatever reason, more reactive. And we feel like some of those areas that are more reactive are usually related to some internal pathology. Maybe it's a latent trigger point. Maybe it's an active trigger point. Maybe it's an area of tightness. Okay, so we'll leave that one there. You don't have to leave them in. In some cases, I won't leave them in. If it was in the lung field, maybe in the upper traps or something like that, and the rhomboids, I wouldn't leave them in, right? Because if I let go of the skin, I can't control where the needle is in space. And so I wouldn't want that to inadvertently hit something that I'm not intending to needle, right? So we'll drop another one right through there. There we go. Okay. Same thing with the soleus. Come a little bit further down. You can almost kind of come a little bit off to the side. So we're going to have to sometimes penetrate the fascia, and you can really see that big contraction there. His foot actually kicked. So what I use a lot of too is I use a lot of electrical stim with the modality itself, and for two reasons. Being a teacher, it's really nice to use the stim because it confirms to me and anybody that I'm showing, I know where I am. I know exactly what tissue I'm hitting because I'm going to make his foot pulse. Right. The other thing too is there's also believed to be just the same thing as TENS. You can change the frequency and cause different types of changes. I can turn it up high enough and create tetany out of this muscle. It's not very comfortable, but I can do that. So if I was using it in for maybe quad contraction, I could turn that on and get a very specific vastus medialis obliquus contraction if I really wanted to. Most cases I use it at a medium frequency because I'm not trying to induce tetany. I'm looking for kind of some of that pain fatiguing response. Okay, so what we'll do, you'll kind of see what this looks like. There you go. You can see that minimal, right? So all bear with me. So there's no doubt where I am at that point, right? We're getting straight plane, plantar flexion with a little bit of inversion. Perfect. Gastroc. So we'll come down here and see if we get the same response. Yeah. So some of the soleus as well. If we can isolate the soleus. There we go. Isolated soleus. So again, it's helpful, right? It's really affirming for my end. It's like, oh, perfect. I'm exactly where I thought I was going to be. I know exactly what I'm in. I'm in soft tissue. I'm not going to contract a vein. You're not going to see that. So the next question usually I get asked is how long are you going to leave them in? You're going to leave them in for a while. There is some research that's recently been published regarding changes in blood flow to the area. They suggest around 10 minutes will create a hyperemic response, an increase in local blood flow. In which case, that's typically what I go for if patients can tolerate it. Not everybody's going to tolerate it. How many needles do I put in? Depends how aggressive you want to be. First couple sessions, probably not going to do a whole lot, especially if somebody's really anxious. It does help a lot that I'm putting him prone, right? If I was going to do the quads, you're sitting, you're watching this. A lot of people aren't too keen on getting needles stuck in their leg. And so it depends, really depends on that. But usually I'll leave them in for anywhere from 5 to 8 to 10 minutes, depending on the region. I'll stim them a little bit and then kind of let them marinate like I tell them, and I'll leave them there. This is out in public.